Good evening, ladies and gentlemen. On behalf of my colleagues in the organizing committee of Dubai Pediatric Club, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the globe, especially from India. This webinar is semi-accredited in collaboration with NMC Specialty Hospital Dubai and is sponsored by Vitabiotics UAE. I would like to thank the country business manager of this company, Mr. Tawfiq Ali, who always support us. Well, today we have eminent speaker and distinguished panelists. In a short while, I'll be introducing them. Their profiles have been circulated. We have Dr. Anurag Vajpayee, consultant pediatric endocrinologist from India, Dr. Asma Dev, consultant pediatric endocrinologist from Abu Dhabi, Dr. Nando, consultant pediatric endocrinologist from Dubai, and we have a distinguished moderator. Dr. Joshi unfortunately lost his mother-in-law. We sympathize with his sorrow. He won't be able to join us. Today's session will be moderated by Dr. Kalpana and Dr. Diari. Well, not moving this slide. The slides are.
Yes.
Yeah. Well, always we have a question. Now I would like to ask all the viewers to identify these two gentlemen in black suit. If you tell us who are these scientists, doctors, and why they are important, I mean, how their contribution to the field. The person who answers right will get a good prize from Mr. Tawfiq. Well, welcome to Dubai, Sheikh Zayed Road in the daytime and Sheikh Zayed Road at nighttime with the background Burj Khalifa. Those who have not seen Dubai, please come and see this beautiful city. Well, on behalf of all members of Dubai Pediatric Club and on behalf of the organizing committee, once again, I would like to welcome all viewers, the members of the organizing committee, myself, Dr. Rajendra Joshi, the past president, Dr. Kalpana Singh Gupta, secretary of the club and moderator today, Dr. Diari Muhammad, chairman of the academic affairs and moderator, Dr. Muhammad Amir Toleimat, Dr. Ayman Jundi, Dr. Rafia Ora, Dr. Srinivas Vandari, our honorary member, Dr. Leila Al-Bahri, and Dr. Khalid Rashid. Well, as I said, today we have eminent speaker and distinguished panelists. Dr. Anurag Vajpayee, consultant pediatric endocrinologist from Kanpur, India. Of course, at the end, I will give more detailed introduction. Dr. Asma Dev, consultant pediatric endocrinologist at Sheikh Shaqut Medical City, Abu Dhabi, and Dr. Nando, consultant pediatric endocrinologist at Al Jalila Children's Hospital, Dubai. Well, we'll have a moderator, Dr. Kalpana Singh Gupta, senior specialist pediatrician and head of department at NMC Specialty Hospital, Dubai, and secretary of the club, and Dr. Diari Muhammad, as I mentioned, senior consultant pediatric surgeon at Al Jalila Children's Hospital and the chairman of the academic affairs. Well, we have our annual conference on Saturday and Sunday, 26, 27 November 2022. Please save the date. Well, Mr. Tawfiq, since 2015, is sponsoring all our meetings, webinars. So we would like to thank him. Well, always I start in the memory of Hippocrates, the father of medicine. I'll give a very brief account of pediatric and history of pediatric endocrinology in the last 7 to 10 minutes. Well, the question, those who have answered right, they will get a prize. Dr. Lawson Wilkins, the father of pediatric endocrinology, and Dr. John Money. I will tell about them. Well, this is a book written by Claude Mission, the student of Dr. Wilkins and his daughter Elizabeth Wilkins, about Dr. Wilkins. Well, after his talk in 1950 at Zurich, the pediatric endocrinology was born. Most pediatric endocrinologists in North America, many from around the world, can trace their professional genealogy to Dr. Lawson Wilkins. So he is the father. Well, Dr. Lawson Wilkins founded the first pediatric endocrine clinic in the world at the Harriet Lane home in Baltimore in 1935. His book, The Diagnosis and Treatment of Endocrine Disorders in Childhood and Adolescence, is internationally accepted as an authoritative text in the field. And here you see in front of Harriet Lane, they are there with Dr. Money, Dr. Majan, his always right hand. Well, about Dr. Money, actually Dr. John Money was a New Zealand psychologist, sexologist, and author. Why I'm mentioning, because today talk is about DST, and author known for his research into sexual identity and biology of gender. Dr. Money introduced the term gender identity, gender role, and sexual orientation. Well, working with endocrinologist Mission, the student of Dr. Wilkins, Money established the Johns Hopkins Gender Identity Clinic, the first clinic in the United States to perform sexual reassignment surgery on both infants and adults. And Dr. Lawson Wilkins was a pioneering pediatric endocrinologist. He is known, along with Dr. Money, for pioneering surgeries for visibly intersex newborn. So remember them. Well, this is in front of Harriet. I love this picture. This is Dr. Wilkins, right hand Mission, left hand Belisard, and this is Dr. Money, always together. And Dr. Nandu likes this picture. This is Lois, at his first place, that this was a child diagnosed in 1951 with congenital adrenal hyperplasia, who received treatment of cortisone for the first time. I love this picture. Whenever I get time in pediatric endocrinology, I mention this is Dr. Lawson Wilkins in 1963. Before his death, he was going to die. He called all his fellows, and these doctors here, they are the ones who describe most of the syndromes and diseases in pediatric endocrinology. Well, a bit about the pediatric endocrinology in Europe. In 1962, Professor Andre Preder invited 26 pediatricians and endocrinologists with an interest in fetal and pediatric issues to attend an informal post-conference meeting. And so the first pediatric endocrinology club later on became European Society of Pediatric Endocrinology. Our panelist, Dr. Asma Deep, is the active member of this society. The ESP was officially founded at a meeting in Copenhagen in 1965, just to remember. And this is Dr. Preder, was a Swiss scientist, physician, and pediatric endocrinologist. He co-discovered Prader-Willi syndrome and created two physiological sex developmental scale that today they will talk about that. Prader scale and orchidometer. Dr. Andre Prader Prize is an annual leadership award established in 1987 and given to the members of European Society. Well, pediatric endocrinology in India. The Pediatric and Adolescent Endocrinology chapter of Indian Academy of Pediatrics was formed in 1987 by founder chairperson Dr. Meena Desai at Vijayawada Children's Hospital, Mumbai. At that time, Dr. Polako was the secretary. Dr. P.S.N. Menon at All India, now in Kuwait. All India Delhi, and Dr. Raghupati at CMC Vellore joined hands with them. So they are the pioneers in India. Well, in the UAE, In Dubai, the first pediatric endocrinologist was Dr. Hassan Mundi, consultant pediatric endocrinologist at many hospitals, Dubai, Suleiman Habib, and now at Al Jalila Children's Hospital. In Abu Dhabi, our panelist, Dr. Asmadib, consultant pediatric endocrinologist and chair, Sheikh Shahbaz Medical City, Abu Dhabi, established endocrine services initially in the private sector and then in the government sector. And in LA, Dr. Walid Kaplan, consultant pediatric endocrinologist at Tawam Hospital, LA, was the founder. So remember them. Well, our hero, Dr. Anurag Bajpai, a profile has been sent to all the groups. For the sake of time, I am not going through that. He is the consultant pediatric and adolescent endocrinologist at Regency Center for Diabetic and Endocrinology Research at Kanpur, India. Well, they are the, once again, I'll tell about the speaker, Dr. Anurag Bajpai, consultant pediatric endocrinologist at Regency Center for Diabetes, Endocrinology and Research, Kanpur, India. Dr. Asmadib, consultant pediatric endocrinologist and chair, Sheikh Shahbaz Medical City, Abu Dhabi, and Dr. Nandu Dalange, consultant pediatric endocrinologist at Al Jalila Children's Hospital, Dubai. Well, I end with a quotation with the father of medicine, Hippocrates. Some patients recover because they believe in doctors, like our panelists. Beautiful Dubai, daytime, nighttime. Thank you very much. Now I end here. Now I would like to request our speaker, Dr. Anurag, to start his talk. Thank you very much. I would like to request all viewers to write their question in Q&A box at the end of Dr. Anurag's talk. There will be question and answer by our moderator. Over to Dr. Anurag, please.
A warm thank you and to Dr. Saurabh and the entire Dubai Pediatric Club team for inviting me for this wonderful opportunity to interact about a topic which is very close to my heart of pediatric endocrinology. What we're going to do over the next 50 minutes or so is to go through three very important aspects of pediatric endocrinology, namely DSD, hypoglycemia, and a bit about diabetes. And then we will have much more detailed discussion in the panel with Dr. Nandu and Dr. Asma. Now, all of you can go and have a look at our YouTube channel, which has got a huge amount of information, including 300 videos on different aspects of pediatric endocrinology, as well as our learning portal, which is learning.growsociety.in, which has got a lot of resources in terms of pediatric endocrinology in the form of videos, in the form of courses. We also run a hybrid fellowship program and a number of smaller courses in that perspective. Our publications are available both in the hardcover as well as Kindle form. And most importantly, we are trying to ensure evidence-based management of pediatric endocrine disorders with the help of our mobile applications, which I'll be discussing with in detail from there, in the form of MediClasses endocrinology app, which is available both on Android and iOS store, and which is quite evidence-based, and we have proved in that perspective. So today we'll be talking about three topics. As I said, we'll start off with one which is considered to be one of the most complicated in terms of clinical practice, one of disorder of sexual development. Now, before we go into that, we need to really understand what really is sexual development. We all know that we all start with a single cell, which is bipotential in that regards. And from there, we have got established genders in the form of boys and girls. And we know there's a lot of fluidity which is happening in that regards. So from there, we have got a stepwise process of development starting, which is regulated initially by genetics, into the development of the gonads and their differentiation. Along with the gonadal development, we have the development of kidneys and the adrenals. So there are disorders which are associated with gonadal development may also have renal and adrenal effects as well. Subsequent to the development of gonads, we have the hormones, testosterone and estradiol, which are formed, which then act on their receptors to cause external appearance. And then finally, we have establishment of the gender identity. Now, the XY group of disorders, or what we can quote unquote say male disorder of sexual development, are largely acts of omission. So if you have no gonad, if you have no testosterone, if you have no androgen receptors, you will basically have a disorder of sexual development and result predominantly as a female phenotype. Conditions which are associated with genetic disorders and affect the testicular development and the gonadal development are often associated with renal abnormalities in the form of renal dysgenesis and WT1, along with adrenal abnormalities. Now, if we do not have the gonadal development, the anti-Mullerian hormone will also not be formed, and therefore uterus will be present. So the presence of uterus in an XY individual means a bi-compartment effect of the testis in which both Sertoli as well as Leydig cells are affected. However, disorders which are associated with defects in testosterone production or action will not have a uterine development because AMH production will be normal. The testosterone defects can often be associated, if they are proximal, with adrenal effects in the form of congenital adrenal hyperplasia, causing salt wasting, which we need to be wary about in that perspective. Then we have the receptor defects, so receptor and hormone. So inefficient testosterone effect will have no uterus, and this is, I think, something which is very important to identify there. On the other hand, the XX-DSDs are largely acts of commission, so we need to have more androgens, which may come either through the ovaries or more classically through the adrenals, which is what is known as congenital adrenal hyperplasia. Very importantly, there will be no gonads in that perspective. Throughout this section of the talk, I'll talk about the most important parts of evaluation of a child with DSD is whether there are gonads or not, and whether there are uterus or Mullerian structures or not in that perspective. So DSD, as discussed, could broadly be XX, which is by far the most common ones. Typically, you will have the Mullerian structures, but gonads will not be there. XX-DSD can be because of androgen excess, most commonly because of 21-hydroxylase deficiency, which will be associated with salt wasting, and 11-hydroxylase deficiency, in which you will have hypertension and hypokalemic alkalosis. You can really have an ovarian excess in the form of aromatase deficiency characterized by maternal virilization. So if you have a history that mother had hirsutism, had hair growth, start thinking of a possibility of an aromatase deficiency in that perspective. There can, of course, be gonadal dysgenesis, which can also cause XX-DSD. The XY-DSD, although is less common, but is more complicated because the etiology is very wide. It is characterized by the presence of gonad, but no Mullerian structure. XY-DSD can be because of dysgenetic gonads, in which gonads are not formed, or it can be a problem of testosterone production or action, as we discussed. Finally, we can have more complicated forms of DSDs, which are more because of mosaicism, of chimerism, in which you can have both gonads and Mullerian structure. So if you look at these two into two table, you will be easily identify. If you have only uterus, this is XX-DSD, only gonads, this is XY-DSD, both you're talking about a 6 chromosome DSD. If you have none of these, it basically implies that at some point of time there was the testis which produced AMH, which is not functioning. So either this is an intra-abdominal gonad, or you have an AMH problem, AMH resistance, or anorchia. So just by looking at these two things, you can identify which class of DSD you are looking at in that perspective. Now, a pediatrician who is faced with a child with DSD is posed by three basic questions. Is it DSD? What type of DSD it is? And finally, what's the cause? So anybody who has obvious atypical genitalia, bilateral cryptorchidism with a normal penile can also be a marker of a XX-DSD, as would be pinoscrotal hypospadia. So in a phenotypic male, if you have bilateral cryptorchidism, severe pinoscrotal hypospadias, or hypospadias with undescended testis, you need to do a workup. In a phenotypic female, the presentation may vary from an obvious abnormality which is there, but you can also have a scenario in which you just have an inguinal gonads, which may be an indicator of a XY-DSD, or if there is a labial fusion. Now, what's very important to understand is that often these DSD individuals may present in puberty with primary amenorrhea or virilization during puberty. So XX-DSD may have a late manifestation. XY-DSD would probably present at a much earlier stage in that perspective. It's also very important to understand what is not DSD, so as to not do unnecessary workup and don't waste enough of resources on that. So if you just have a prominent clitoris without a labioscrotal fusion, don't worry. This is very, very common in preterm girls. Don't need to bother about that. If you just have a penile hypospadia, it's very unlikely to have a disorder of sexual development. Forget about that. If you have this scenario in which there is a labial addition, but there is no clitoromegaly, this again is not DSD. So identifying just a prominent clitoris, a penile hypospadia, and just a labial addition should not warrant evaluation for DSD clearly in that scenario. Now, how do we classify? And as I said, you have to do a very careful examination. Look at the phallic length. So if the length is less than 2 centimeters, generally we call it micropenis. If it's more than 1 centimeter in clitoromegaly is what is defined, but we should use the term phallus to be more non-committal in that perspective. Also feel for whether there is an erectile tissue there or not. Now, if there is any round structure which is there, it is usually a testis. Rarely you can have a prolapsed fallopian tube. And if there is a heterogeneous structure, this could be ovotestis. So feel for the structure right from the inguinal canal to the base of the scrotum, and that's very, very important. Now, Boolean structures can be looked at either via rectal examination or more commonly using ultrasound. Now, remember that there is a lot of estrogen exposure at this age group, so the uterine size is reasonably big. So a radiologist should be able to pick up on ultrasound whether the uterus is there or not. So if I will say the most important thing to look at is whether gonads are palpable or not, and whether uterus is present on ultrasound or not. And that forms the basis of classification. So if you have only the uterus present and no gonads, it's XX DSD. Think of 21 hydroxylase deficiency as the most common cause, followed by 11 hydroxylase and probably aromatase deficiency. If you have a testis which is present, but there is no Mullerian structure, it is usually XY DSD. Think of a gonadal dysgenesis, or think of a steroidogenic defect, or inefficient androgen action in the form of 5-alpha reductase deficiency or androgen insensitivity syndrome. If both these structures are present, it's a more complicated scenario. There could be an asymmetry of genitalia, which will give you a clue of ovotesticular DSD. And finally, if you have both which are absent, it basically would mean that there was at some point of time testis there which produced AMH. This could be an abdominal gonad or could be anorchia. So as I said, if you remember this slide, you can easily classify and then decide how do you progress from that regards. Now, karyotype, of course, is essential. You should go for 50 metaphases because there is a huge amount of mosaicism which may be there. So even if you have 1 or 2 cells, you may have variations which are there. In rare cases, it may be required to do a gonadal karyotype to get a more specific diagnosis. We can go for fish for Y-line, which will give you a quick diagnosis, but karyotype is very, very important in that perspective. Now, once we know which group it is, we then go for the cause. And for that, we have to decide which test to order, when to order, and how do you interpret. So 17-hydroxyprogesterone is very, very important if you have an individual with a non-palpable gonad. This may be a 21-hydroxylase deficiency. Remember, do not do 17-OHP in the first 72 hours. And very importantly, in the newborn period, extracted 17-OHP is important. DHEAs will give you a clue about a combined biosynthetic defect. If it's low, it suggests a proximal defect. If it's high, it is 3-beta hydroxysteroidehydrogenase deficiency. Androstenedione will help you identify the 17-beta HSD defects. Testosterone will give you information about Leydig cells. And dihydrotestosterone will tell you about whether there is a problem in 5-alpha reductase. So if you remember these tests, you will be able to identify most diagnoses in that regards. AMH could be used for the marker of Sertoli cells. So typically in XY, the levels are pretty high, more than 30. So often there is no confusion in that regards. Now, a big question comes as to when should you be doing androgens? And that's important because there is a lot of variations in terms of the hormone levels. There is, very importantly, a mini puberty which happens, and often people ask whether we need to do a stimulated or a baseline sample. So HCG test is recommended if your LH level is less than 0.7, which means the mini puberty has not started or it's already stopped in that perspective. You would give HCG, and at 0 and 72 hours, you look for testosterone, dihydrotestosterone, androstenedione, and you will get the information from that perspective. Now, once you know it is XX DSD, your differentials are limited to 21 hydroxylase, 11 hydroxylase, 3 beta, and aromatase. You look at 3 basic tests. If the 17-OHP is very high, this is 21 hydroxylase deficiency. If you have a high but not very high, it could be 3 beta. If your DOC is very high, there is hypertension or hypokalemic alkalosis. This is 11 hydroxylase deficiency, while you can really have a POR form as well. So looking at these 3 metabolites will give you a clue in that regards. What about XY-DHT? The most important are DHEAS, androstenedione, testosterone, and DHT. If all are low, this is a proximal defect. If DHEAS is high, rest is low, this is 3 beta HSD in most cases. If you have a high androstenedione to testosterone ratio, this is 17 beta HSD defect. If you have high testo, but DHT is low, this is 5 alpha reductase deficiency. And if all is high, it is androgen insensitivity. So if you combine these 2 slides, you can easily interpret these informations in that regards. So how do we approach a child with DSD? If there are palpable gonads are absent and Mullerian structure is present, so this should be present, not absent, you look at 17-OHP. If it's high, this is congenital adrenal hyperplasia. If it's normal, look for aromatase deficiency and really dysgenesis. If you have palpable gonads and Mullerian structures are also present, this is a rare scenario. Look at AMH levels. If AMH is low, this means it's a dysgenesis. If AMH is high, this is AMH resistance. If, however, you have got no Mullerian structures, whether palpable gonads are present or not, it means that this is a XY-DHT. In that scenario, look at testosterone. If testosterone is low, along with that, you have salt wasting. This is CH. If you have hypertension, it is 11 hydroxylase deficiency. If you have a normal salt status, it is 17 beta HSD defect. If, on the other hand, the testosterone is high and DHT is low, it is 5 alpha reductase deficiency, and DHT is high, it is androgen insensitivity. So just to summarize, look at palpable gonads and Mullerian structure. No gonads, Mullerian structure present, 21 hydroxylase deficiency, most common, normal 17-OHP, aromatase deficiency. If Mullerian structures are present and palpable gonads are present, it is a rare scenario. If Mullerian structures are absent, work up for XY-DHT, look at testosterone, look at DHT, and look at salt wasting, you will get the diagnosis. Now, this is the nutshell in terms of evaluation. Now, this can become a bit complicated. So what we've done is that as part of our MediClasses app, we have developed a specific DSD interpreter in which all you have to do is to first decide whether the gonad and Mullerian structures are there or not. And based upon that, you will be asked specific questions for each groups, and you will get a particular diagnosis as you enter in that regard. So if you go for that, you will get a likely diagnosis. This will be different for different scenarios. And this is an easy way of using the evidence base in that regards. And we have validated this in a group of individuals as well in that scenario. So now we'll start with cases. This was a 3-day-old child with DSD, Prader stage 4 with no palpable gonad. So this is clearly going more in favor of a XX-DSD. Uterus was present. So this is XX-DSD. Now in XX-DSD, what we need to look at is basically whether there is maternal virilization or not. What is the 17-OHP? So that becomes very, very important. Now 17-OHP in this case is pretty high. And we have hyponatremia and hyperkalemia. So this is a classical scenario of salt wasting CH. So if you have a lack of palpable gonad and there is Mullerian structure, go for 17-OHP. Similar scenario, day 3-year-old child looks like a micropenis, but there is no gonad. So remember, bilateral cryptorchidism is a marker of DSD. Now, this again is the XX-DSD. So we look at 17-OHP, which is normal. So what do we do here? We basically, a very, very important question in this scenario is to ask for maternal virilization. Now here, mother gave a history that during pregnancy, there was some hair growth, there was some acne, and that gave us the clue that this is aromatase deficiency. So XX-DSD with a normal 17-OHP, ask for maternal virilization and you will get a direct diagnosis of aromatase deficiency from there. A bit different, we have got bilateral gonads. As you can see, there is no uterus. So gonads present, uterus absent. This is XY DSD. Classically, in this scenario, of course, the questions will be different. The most important thing here would be whether the testosterone is low or high, whether there is salt wasting or not. So let's see. Testosterone was on the lower side. There was hyponatremia with hyperkalemia and a high 17 OHP. So what do you think are we looking at? This is a XY DSD who has got hyponatremia, hyperkalemia, and a mildly elevated 17 OHP. The diagnosis in this scenario is 3 beta HSD. So XY DSD can also have salt wasting, but that will be rarer scenario in that perspective. Again, a day 14 child, and what we see here is very, very interesting. One side is looking like a scrotum, the other side is looking more like a labia. So this is an asymmetrical genitalia. Now, interestingly, there is one side testis, the other side uterus is present. So there is both testis as well as Mullerian structure, which makes things confusing. So this clearly is asymmetrical genitalia is present, and that will give you a direct clue in that scenario that this is a ovotesticular DSD in that regard. So just looking at the gonads, looking at the Mullerian structure, 90% of your work is done in that scenario. Now, we have got some older individuals who can also present with DSD, and this is often interesting. 15-year-old girl with delayed puberty. Now, she had an inguinal gonad. Now, in this scenario, we looked at Mullerian structure, which was absent. So this looks like a XY DSD. Testosterone levels, FSH was very high. Testosterone is 0. So this is a child who is presenting like a female, but it's actually a XY individual. And most important thing here is that the child had hypertension. So hypertension with delayed puberty in a girl with inguinal gonad, the only diagnosis you will think of is 17-hydroxylase deficiency. So look at blood pressure, you get the diagnosis. 11-year-old boy, now this is the opposite picture. 11-year-old boy with early puberty who is very short, stage 4 pubic hair, but no gonads. So no gonads and Mullerian structure is present. So this is interesting. That child had no Mullerian structures in gonad, but behaving like a female. This boy apparently has no gonads and has uterus present. Again, the common thing is that he also had hypertension. So this was a clue of 11-hydroxylase deficiency. So basic clinical clues can give you the right diagnosis in the right time in that scenario. 10-year-old girl with clitoral enlargement. Now, this is interesting. She was being reared as female and suddenly the clitoris is enlarging. Now, here the phallic length has gone to 2.2 centimeters. There is bilateral gonad. So often these XY DSDs may present a bit later as well. But what's important is that uterus is absent. So this child is not producing enough testosterone during the fetal period, but AMH was produced. So therefore, there is no uterus. Karyotype is XY. Testosterone levels are in the male range. And what we see here is that the testosterone is high, but it is not converting to DHT. So if you have a pubertal virilization, the most likely diagnosis here is 5-alpha reductase deficiency, which you have to consider in that scenario. Now, the big question is what gender shall we rear, which is often a very debatable issue. And this becomes complicated because we have to look for gender identity, social factor, fertility, and sexuality. So all these factors are important. Very importantly, if somebody is antenatally exposed to androgens, there is virilization of the brain as well, so to speak. There are cultural issues, and most cases of 5-alpha reductase would better be managed as reared as males, because otherwise there will be issues of gender identity later on. Final case in DSD, 15-year-old girl with primary amenorrhea. Height was reasonable. There was breast stage 4, but very sparse pubic hair. And there were inguinal gonads. Now, Mullerian structure was absent. So again, it looks like a XY DSD with a normal female appearance presenting as primary amenorrhea with sparse pubic hair. The diagnosis here is written on this clinical scenario that this is a classical scenario of partial or a complete AIS in that regards. Testosterone was high. DHT was also high. So this is complete androgen insensitivity syndrome. The big question here is whether we go for gonadectomy or not. And this is also an important question because we know that if there is a Y cell line and there is a dysgenetic gonad, there is a risk of malignancy. Now, gonadal malignancy risk depends upon the etiology. So it's high for the gonadal dysgenesis. It is particularly for Y cell line. If there is a steroidogenic defect, the chances are less. If the testis is in the abdomen, of course, the risk is very high. Scrotal, the risk is low. Very importantly, if the androgen exposure is more, there is increased risk as well. And if there is a streak gonad, the risk is more. So when you're deciding about the need for gonadectomy, you have to consider all these scenarios in that regards. So if you have an abdominal gonad with a Y cell line, you have to remove it. If there is an impaired DHT effect like complete AIS, the risk is much lower. So just to summarize the various conditions, the most common is XXCH, usually rare as female, no risk of gonadectomy, fertility is good. But if you have a very virilized XXCH who presenting late as a male, sometimes around 10 years of age, you may think of rearing as male, no need of any gonadectomy in that regards. If, however, you have got a XXY DHT, the risk of gonadal tumor is high, you have to go for gonadectomy. If you have a XY DHT, usually the identity is male, so you continue as male. Gonadectomy again has to be done at an early stage. If you have a XYCH like 3 beta HSD, again identity may be female, but depends upon the androgen exposure. Very importantly, you don't need to worry too much about gonadectomy. You may think of gonadectomy around puberty. For 5 alpha reductase, you have to do orchidopexy and monitor, rear as male. For complete AIS, rear as female, and don't do orchidectomy early, do it after puberty. And for partial AIS, it is very, very difficult to decide orchidectomy is required if it's abdominal. So if you remember this table, you will know how to really manage a particular group of DSD in terms of fertility, in terms of gender of rearing, and in terms of gonadectomy. So I think what we have tried to do is to cover the entire aspect of DSD in a very short time. And of course, we have got this limited time, but we can discuss more on panel. We try to cover the key messages. The most important message is to consider DSD in anybody who has got bilateral cryptorchidism, girl with primary amenorrhea, girl with femoral hernia, or inguinal hernia, always think of DSD. Gonads, Mullane structure, very important. They will help you classify. And then, of course, you want to exclude emergencies like CAH right away by doing a 17 OHP in somebody who has a non-palpable gonad. So I think what we'll do now is that we will move from DSD to the second group of disorders, which is, again, a bit confusing, of hypoglycemia. Now, just to have a basic physiology again, hypoglycemia basically is prevented by 3 mechanisms. Of course, we eat very frequently, we will be having enough glucose. The first defense is from liver, produced by glycogen, so using the glycogenolysis pathway, which kicks around 4 to 6 hours, lasts for around 12 hours. Second is, of course, the process of gluconeogenesis from kidneys, muscles, where the non-carbohydrate sources produce glucose, start around 12 hours, last for around 24 hours. And finally, we've got the alternate source of energy, which are ketones, which start kicking by around 18 hours or so, and then they will take care of till 48 hours. So if you have a defect in glycogen production or its metabolism, it will have an earlier presentation when the gap is beyond 6 hours, typically around 6 months to 12 months of life. Gluconeogenic defects will present later because you need a gap of at least 12 hours. So they will present around 1 to 2 years of life. And ketogenic defects, fatty acid oxidation defects may present even later because you would need much longer fasting for this to happen. And they may actually present only when you have fever or some intercurrent illness. As we have got 3 different organs, there are 3 different group of hormones which control the glucose level. Insulin is the only one which decreases glucose. And of course, glucagon, cortisol, epinephrine, growth hormone, they all increase the level of glucose. So if you have high insulin, you will of course have hypoglycemia. But if you have deficiency of just one counter-regulatory hormone, you will not have hypoglycemia. So there is a redundancy there. So if you want to have hypoglycemia to happen, you will need to have a multiple hormone deficiencies, classically a growth hormone and cortisol deficiency, like multiple pituitary hormone deficiency. Now, insulin excess in particular is very, very important and common cause associated with a non-ketotic form of hypoglycemia. Now, this is very important. Everybody who becomes hypoglycemic should produce ketones because that's a normal response. If your ketones is not being produced, one cause could be that the insulin is high or there is a problem in ketone production. So ketones is the most important investigation in a child who presents to you with hypoglycemia. Defects in cortisol production typically will present a ketotic hypoglycemia with also affects their sodium axis. You will have hyponatremia. Defects in glycogen production, which is glycogen storage disease, will typically present around 6 months to 12 months of life with huge hepatorenal, very much amount of ketones. Now, these ketones will save their brains because ketones are the alternate sources as far as energy is concerned. So for the same level of hypoglycemia, hyperinsulinism, which will be much more devastating for the brain as compared to a glycogen disorder or a disorder in which you have got a higher amount of ketone production. Defects in the setting of gluconeogenic defect will present around 1 to 2 years of age with significant lactic acidosis. While defects in the growth hormone and cortisol axis will present with multiple pituitary hormone deficiency, typically with neonatal cholestasis, micropenis, midline defects, and these conditions are very important from that regards. Ketone production defects like fatty acid oxidation defects will present with episodic production with low level of ketone. So this is pretty much the etiology of hypoglycemia. Now, very importantly, how does body respond to hypoglycemia? Once your glucose becomes below 50, the first thing is shutdown of insulin, which should become undetectable. There would be an effect with regards to a rise in ketones. So everybody who is hypoglycemic should have a ketone more than 2 millimoles per liter. We're talking about blood ketones here. Should also have a high level of cortisol above 550 nanomoles per liter and a high level of growth hormone above 10 nanogram per ml. And lactate should remain low. So this is a normal response. And this is important because this is what we know as critical samples. So when you have hypoglycemia, you should assess insulin, ketones, growth hormone, cortisol, and lactate. And I'll show you how that will really make your diagnosis very easy once you look at it. Now, if you have hyperinsulinism, you will have detectable insulin. Any insulin during hypoglycemia is significant. This becomes hyperinsulinism from that perspective. If you have low levels of ketones, that is suggestive of an insulin excess, fatty acid oxidation defect, or galactosemia. If you have a lactate which is not high, you're thinking of GSD1 or a gluconeogenic defect in that perspective. Similarly, if the growth hormone and cortisol levels are not high enough, you're talking about a multiple pituitary hormone deficiency in that scenario. So if you talk about the various forms of these defects, we go by one. We'll see clearly that if your insulin is ketone is low, you're talking about hyperinsulinism or a fatty acid oxidation defect. High ketone, all other causes. If lactate is high, you're talking about GSD1 or gluconeogenic defect. If you have acidosis, again, organic acidemia, GSD1 and gluconeogenic defect. If insulin is detectable, clearly this is hyperinsulinism, and we can really go for glucagon test, which I'm not going to focus too much. Focus on these 3 parameters: ketones, lactate, and insulin, and your diagnosis is done very easily in that regards. Now, what we need to remember is that high insulin is the least common parameter which you observe in hyperinsulinism. And remember, there will be 18% cases in which the insulin may be undetectable. So just by having an undetectable insulin, you cannot exclude hyperinsulinism. C-peptide is a much better marker, which we are using more often these days, as are a hypoketotic state with a good glucagon response. Anybody who is hypoglycemic should have exhausted the hepatic resources. There should be no glucagon response, but if there is a glucagon response, it's an anti-insulin hormone. So therefore, you will know that this is hyperinsulinism. So if in doubt, always go for glucagon response in hypoketotic hypoglycemia. If you have hypokalemia, which is the effect of insulin, and the glucose infusion rate is very high, start thinking of hyperinsulinism in that scenario. So how do you approach hypoglycemia? Look at ketones. If the ketones are low or absent, look at reducing substances. If they are positive, it is galactosemia or fructose intolerance. If they are negative, look at insulin. If you have undetectable insulin, this is fatty acid oxidation defect. If it's detectable, it is hyperinsulinism. If the ketone levels are high, you're looking at a different group altogether, and your lactate is also high. You're looking at GSD or gluconeogenic defect. If you have a normal lactate level and there is a huge hepatomegaly, these are GSD variants. If there is no organomegaly, look at cortisol and growth hormone, and only when you exclude that, go for a diagnosis of accelerated starvation. So this is how we look at ketones. If they are absent, look at reducing substance and then insulin. If they are high, look at lactate, look at cortisol and GH. And when you go on to that, you will find ketotic hypoglycemia or accelerated starvation, which is the most common cause, but it's a diagnosis of exclusion, which is very, very important from that perspective. So we'll go to cases. 3-week-old boy with seizures, sugars is 28. First thing to look at is ketones. So ketones are positive, so hyperinsulinism becomes less likely. The next step is lactate, which is normal, but sodium is low. Now, this is important. You have hyponatremia with hypoglycemia. The diagnosis is very, very going towards in that direction. There is micropenis as well, and you will find that the cortisol level is low. This is multiple pituitary hormone deficiency. Clearly, your diagnosis is made right away. 3-week-old boy with failure to thrive. Ketone levels are, there is hepatomegaly, and the glucose requirement is not high. So that's why I'm not thinking of hyperinsulinism as a primary cause. Here, ketones are low, which goes more in favor in somebody who has hepatomegaly, a 3-week onset towards galactosemia, in which scenario we should do a reducing substances, which were positive, and then finally the genetic diagnosis of galactosemia is there. So non-ketotic, low insulin requirement, early onset galactosemia is the diagnosis. 14-day-old boy with birth asphyxia in the ICU, blood sugar is low, very high glucose requirement. And high glucose requirement directly means that we are probably dealing with hyperinsulinism here. Ketone is negative and insulin is detectable. So any detectable insulin during hypoglycemia suggests hyperinsulinism. And this child was born with a small for gestational age weight. So this clearly is one of the most common cause of what we know as prolonged hyperinsulinism, which is a stress response in which there is increased production of insulin because of the hypoxia, which they are exposed. They will respond to glucagon, and we can then consider starting hyperdioxide in that scenario. So increased insulin effect, which is largely hyperinsulinism, can be because of a congenital cause, which can be transient. We all know about infant or diabetic mother, and now we know of various other stress conditions which can cause that. Most common cause, however, is the prolonged form, which we are seeing in SGA, lasting from 2 to 6 weeks, very, very well diazoxide responsive. If somebody is not responding to the diazoxide, think of rarer genetic causes in that scenario. And finally, there are rarely syndromic causes, or acquired causes are very, very rare, insulinoma in adolescents, which we should consider. And if everything is favoring hyperinsulinism, insulin is undetectable, think of these rare genetic causes which are there. But the most important cause in the neonatal period is prolonged hyperinsulinism because of SGA, followed by inherited problems in the potassium ATP channel, which are the on-off button, so to speak, of insulin secretion. And this is what we need to understand. So now you have a 3-day-old boy with severe hypoglycemia, macrosomia. So again, there is an antenatal insulin excess, which is there in this child. Very, very high glucose requirement. Ketone is negative. Insulin is detectable. So this is hyperinsulinism written all over. Now, because of macrosomia, we have to start thinking of some potassium ATP channel defects, which are likely in that scenario. So we start diazoxide here. But how do we manage? So if we have a classical setting of a transient cause, like infant or diabetic mother or prolonged cause, you start with dextrose and diazoxide, and usually the management will be good enough. If there is no clear-cut cause of transient, there is macrosomia, like in this case, look for diazoxide response, start at around 5 milligram per kg per day, increase to 15. If it's there, you continue. Look at ammonia, because there is a syndrome of hyperammonemia with hyperinsulinism, which is there, which will give you a diagnosis. But most importantly, if there is no diazoxide response, go for immediate genetics for potassium ATP channel defect. If there is a recessive defect, it is not going to respond. You can intermittently try octreotide, but ultimately go for pancreatectomy. However, if you find a paternal inherited mutation, no genetic defect, or if there is Beckwith-Wiedemann syndrome, there is a chance of a focal lesion, go for a focal fluorodopa PET. If it shows a focal lesion, you can go for surgery. If there's a diffuse lesion, you will need to do a palliative surgery. So if you have hyperinsulinism, the first thing is, without doing anything, start diazoxide. If there is no diazoxide response, go for genetics immediately, and that will decide whether it can be focal or diffuse. If it's diffuse, that's very difficult. You have to go for pancreatectomy, long-acting octreotide. Those are difficult scenarios. But if you identify a single focal lesion on PET, remove it, and the child will be fine. And that would be the ultimate goal in that perspective. So on 10 milligram per kg per day, in this case, we increased to 15, hypoglycemia persisting, nothing is working, we gave glucagon, and then we found that there was a diffuse potassium ATP defect, has to go for surgery and the other management from there. Now we have got a later, older individual, 6-month-old boy with lethargy, blood sugar is 36, ketone in this case is present. So this is a ketotic hypoglycemia. Lactate is also on the higher side. So this clearly goes in favor of a GSD1. There is hepatomegaly. So if you have ketotic hypoglycemia, 6-month presentation, hepatomegaly, renomegaly, high uric acid, high triglyceride, this is classically glycogen storage disease. 1-year-old boy with blood sugar low with no organomegaly. Now lactate level is also normal. Ketone is present. So now we have got a differential of either a hormone deficiency or accelerated starvation or ketotic hypoglycemia. You look at the growth hormone and cortisol, which is appropriately responsive. So this is classically accelerated starvation. So ketotic hypoglycemia of infancy is the most common cause, but it has to be considered only after you've excluded all other causes. Very importantly, all you have to do is to build up their muscle mass, give them a nighttime feed, avoid fasting, and especially during the stress times or intercurrent illnesses, you need to give them more glucose in that scenario. 2-year-old boy, very important case to present because this was diagnosed as ketotic hypoglycemia. Vomiting, lethargy, hypoglycemia, ketone present, lactate normal, no hepatomegaly, diagnosed as accelerated starvation. But we missed one step by the referring physician in that the GH cortisol was not done in that scenario. So what was clearly shown here was that this child had pigmentation, the cortisol was low for the level of hypoglycemia, and this really turned out to be a DAX1 defect. So what is very important is that before you label anybody as accelerated starvation, very importantly, consider a cortisol deficiency in that scenario. So we have tried to cover two very, very complicated topics of DSD and hypoglycemia. We'll now move forward towards more easier, but more important because it's one of the most important chronic conditions that children have in form of pediatric diabetes. We'll try to cover it over another 15 minutes or 20 minutes or so, and then we'll have a lot of panel discussion because a lot of these issues are confusing in that regards. Before we head towards that side, about hypoglycemia, the most important thing to remember is that if you have a neonate who has hypoglycemia beyond 48 hours of life, who is requiring a glucose infusion more than 12 milligram per kg per minute, start thinking of an important cause. The most important test is blood ketone. Always obtain a critical sample. In critical sample, if your ketone is less than 2, think of hyperinsulinism, fatty acid oxidation defect, and galactosemia. If your insulin is detectable, this is hyperinsulinism. If your growth hormone is below 10 and your cortisol is below 550 nanomoles per liter, this is multiple pituitary hormone deficiency. And if your lactate is high beyond 2, it is GSD1 or a gluconeogenic defect. So if you just look at ketones, lactate, insulin, and reducing substance, your diagnosis is done. Management is very simple from that regards. Hyperinsulinism, prolonged form, very common in the neonatal period. Importantly, you think of diazoxide response, very good response. If diazoxide unresponsiveness, go for genetic testing and beyond. So this is what about hypoglycemia, the key messages I wanted to give. Now coming on to diabetes, which we'll be focusing about, we'll start off with the most important aspect of DKA. And we all know that DKA is a very, very important scenario which should be considered in somebody who has unexplained dehydration with polyuria, tachypnea without chest signs, and abdominal pain. You have to think of DKA and encephalopathy. Now we have got this girl who has got very, very severe DKA. How do you manage? Most of what I'm talking today is through the ISPAT guidelines. And all of you can go to the ISPAT website. There's already a document available for the latest guidelines this year, 2022, which will be released during the ISPAT conference, which is going to be held in Abu Dhabi. And Dr. Asma is the lead in that regard. So ISPAT guideline, I'll be focusing about what differences are there in that regards. Now, when we treat DKA, The most important aspect is fluid treatment. As soon as you give fluid, the volume expands and the counter-regulatory hormone go down. So within the first hour, you expect the glucose to go down by around 150 to 200. So do not give insulin at this point of time. If you give insulin here, you will have a rapid fall in glucose, and therefore you will also have hypokalemia, which may happen. But after 1 hour, you start insulin. And once you start insulin, your glucose will fall by around 60 to 100 milligram per DL per hour. So there will be a scenario where you will develop low glucose, but acidosis is persisting when you have to add dextrose. That's typically around 300 milligram per DL in terms or around 16 to 17 millimoles per liter as far as glucose levels are concerned. Now, what's important to remember is that glucose improves by 6 hours, ketones by around 10 to 12 hours. Acidosis may take much longer, and this is because of the hyperchloremic metabolic acidosis which is persisting, and that's something which we have to be careful about. We don't unnecessarily keep on treating with insulin. So if you have somebody who is clinically better, is passing good amount of urine, doesn't have infection, doesn't have a renal dysfunction, this could be hyperchloremic acidosis which will improve over time. The complications which we are really dreading is severe edema. So if somebody has a severe disease, too much fluid is given, soda bicarbonate not given now, but often if somebody is given, think of severe edema. This is the leading cause of death. Very importantly, less fluid, slow correction, consider mannitol. Now, hypokalemia is very, very important because potassium is already low, but falsely because of acidosis and because of insulin deficiency, the potassium becomes high in the extracellular compartment. As soon as you give insulin, there will be hypokalemia. So you supplement the potassium. Acidosis, as discussed, could be ketosis, infections, and hyperchloremic. So never give soda bicarbonate. Other thing to remember is infection. Very importantly, thrombosis. Never put a central line in DKA unless it is mandatory. If you are putting in a central line, you give low molecular heparin, which is very, very important. And rhabdomyolysis, because of hypophosphatemia, is very important. If you have a child who was doing well, suddenly has a leg pain, there is tenderness in the leg, there is high colored urine, it is rhabdomyolysis. Typically, phosphorus will be less than 1. This is a bad sign. This child will now go into renal failure. Be very, very cautious in that regards. So we'll start off with this case, 10-year-old girl, high sugar, severe acidosis, potassium is 5.8, and there is dehydration. So whether we give a bolus, of course. Now, the recent dispatch guidelines talked about 10 to 20 ml per kg over 20 to 30 minutes. If there is shock, you repeat it more in that scenario. Remember that sodium would actually be not as low as reflected by this 130. For every 100 milligram per DL, add 1.6. So sodium is actually 37. So normal saline will be good enough. How much duration? Typically 24 to 48 hours. I'll be happy for 48 hours in this scenario. Start with a maintenance fluid, which is 4-2-1, holiday cigar formula, which is typical, and add maintenance along with that, the deficit, 10 ml per kg, and you get per hour. You deduct the bolus that you have given in that scenario, very importantly. What about potassium? So if you look at the corrected potassium, for every 0.1 fall in pH, potassium actually goes up by 0.6. So here your potassium looks like 5.8, but the corrected potassium is 2.8. So you have to be very, very wary in that scenario. Start potassium here, 40 millimoles per liter in the hydration fluid. Precaution, you have to think of severe edema, very, very significant, pH is 6.92, and hypophosphatemia. Give 50% of potassium correction as K-phos and 50% as potassium chloride in that regard. So phosphorus is low, you have to be wary, give potassium as phosphorus in that scenario. Now at 6 hours, what you're seeing is that sugars are high, acidosis is persisting, ketones are also high. There is improvement, but still the ketones have gone up actually. So what's this happening? You should always monitor blood ketone, but remember that beyond around 5 level of ketone, there is a ceiling effect. So this ketone will not be very reliable in the initial phase. So don't worry, your acidosis is coming down, ketone is still high, that will go down in some time. Don't worry about this in that scenario. 8 hours, your blood sugar is 190 and there is acidosis which is persisting. So here, if you don't add dextrose, you will definitely have hypoglycemia. So in that scenario, you should add 10% dextrose in that scenario, continue insulin, however, in that regards. Now at 10 hours, you have an interesting phenomena of hypokalemia which is developing, and base excess is -11. Now what you need to remember is that this child is not going to die because of this mild metabolic acidosis. He is going to die because of hypokalemia. So what you should do here is reduce and in fact sometimes stop insulin, give magnesium if there is magnesium deficiency, and very importantly, give potassium infusion. So hypokalemia is the second most common cause of death, I would say, in DKA after cerebral edema. You have to be very, very bothered and careful about, and you may give magnesium also in that scenario. Now, after all that, suddenly at 14 hours, the child becomes comatose. So this is classically a case of cerebral edema. Remember, do not wait for imaging, give mannitol. Mannitol and 10% dextrose should always be available on the bedside of everybody who is being managed with DKA. Waiting for imaging would be lethal in that scenario. 20 hours, you are seeing that blood sugar is 190, better. Base excess, there's mild acidosis which is persisting. Now, this I discussed is classically hyperchloremic metabolic acidosis. So what you look at is ketones which are getting better. You see then on chloride load, your chloride is high. So this is hyperchloremic metabolic acidosis. This is self-responding. You don't need to bother about that. It will improve over time. So this is something which is very, very easy from that perspective. Now I'll go into some other scenario. This is an 11-month-old boy with DKA. What do? Bolus. Yes, you have to give. Duration, a bit slow. Maybe you go for 72 hours also or 48 hours, but be very careful of fluid overload. Now here is important. Insulin, we will always use lower. And some people say 0.05 is the standard dose. And some in infants will use 0.025. So less is more in DKA. Less fluid, less insulin. And be very careful about cerebral edema. 4-year-old girl treated outside, severe metabolic acidosis, is drowsy with anisocoria. Now this is important. Already because of fluid management, she went into cerebral edema. Do not give bolus in that scenario. Correct very, very slowly over 72 hours. Insulin start at a half dose. And very importantly, you have to manage cerebral edema right away. Give mannitol and head end elevation and all the parameters are very, very important here. 3-year-old boy with severe DKA, what's very interesting is your potassium is low. So this child has a low potassium at presentation. This is lethal. If you start insulin, he's going to die. So give a bolus. But with bolus, give 10 millimoles per liter, 20 millimoles per liter of potassium in that scenario. Again, insulin should be withheld till the potassium becomes normal. Duration of correction is similar. Worry about hypokalemia in that scenario. Now, 13-year-old girl, severe DKA on treatment, develops oliguria. So this is important. If you are developing oliguria, think of renal failure. Give a bolus, no response, start thinking of other parameters. So here you have got low urine output. It's not pre-renal, not responding. Creatinine is rising up. What do? You of course have to think of an immediate dialysis. Do not wait, because if you wait, this child you're giving fluid suddenly will develop cerebral edema, cardiac failure, and there'll be a huge problem which is there. So hemodialysis is required, but with hemodialysis, what we forgot was that low molecular weight heparin was not given. And that's why DVT can develop. So whenever you're putting a central line in somebody with DKA, always give a prophylactic heparin. And that's very, very important from that regards. So DKA management is a tightrope. If you give less fluid, you will develop longer correction. If you give too much fluid, you will develop cerebral edema. If you give less insulin, you will have a slower correction. If you give too much insulin, you will have hypokalemia. So would you like to do too rapid correction, causing cerebral edema, hypokalemia, and death, or a slower correction? I think the answer is very clear. The mantra of DKA is slow correction, less fluid, less insulin, and there is probably a role of technology. Now, what we have looked into is that despite so much education, despite all the available training that we did, in our ICU also in the first 1 hour, a lot of errors were being done by residents. That's despite all the written protocols which are available. And this had an impact, because if you do wrong in the first hour, you will have a big impact subsequently. So what we developed is that using the ISPAT 2018, and now we are updating it to 2022 guidelines, we developed an app which provides personalized guidance with regards to the amount of fluid, the amount of insulin, the duration of correction, and all the parameters which we talked for the last 10 minutes or so in the form of our app. You just have to put the data. You will get the information on the initial part and the follow-up. And what we have shown is that the use of this mobile application reduces these prescription errors dramatically. So we need to really improve the quality of care because all evidences are there. But unless we use and show this evidence and use it specifically, we will not be able to reach an appropriate one. And this is one way in the direction we tried to improve quality of care in that perspective. So we have tried to cover about DKA. Maybe we'll have 5 to 10 minutes. Do we have, Dr. Saurabh? So I think just continue on.
Sure, doctor.
Yes, yes.
Go
please.
ahead, doctor.
Yeah, thank you. So this will make it much easier for the panel as well. So we had this 8-year-old boy with weight loss and a blood sugar of 320. Now went to a pediatrician who said, okay, sugars are high, let's get a glucose tolerance test and a HbA1c done. The child came 2 days later. At that time, the report showed a high fasting sugar, a high 2-hour value, and HbA1c was very high. But unfortunately, this child had developed DKA. So this is a big message. If you have high sugars in a child, it's an emergency. Do not go for a glucose tolerance test. Do not go for HbA1c. Type 1 is a dire emergency. Now, the diagnostic criteria for children and adults are the same ADA criteria, which basically talk about fasting levels beyond 126, 2-hour value or a random value, glucose load of more than 200 being significant. And for adults, particularly HbA1c, if it's standardized via the assay which is used in DCCT, they use the HbA1c as well. Now, I have a few problems with adolescent diagnosis based on HbA1c, especially at levels between 5.7 to 6.5. It doesn't have a very good correlation. So if for type 1, there is no confusion. For type 1, you immediately confirm, and the sugars will be very high usually. Do not wait. For other parameters, you can look for repeat, but be having a bit of a concern with regards to the HbA1c level. Don't just go for HbA1c. There is no role of oral glucose tolerance test in type 1 because type 1 is an emergency. High sugar, get ketone, exclude DKA, start insulin. And HbA1c is variable diagnostic accuracy in children. This is what I like to say in that perspective. Now, this child post DKA was started on a sliding scale insulin. Now, this is something which we should definitely avoid. Start basal bolus right from the offset because this will give you a much better control. And remember, the initial requirement will be very high in that regards. So when we talk about type 1 diabetes management, there is a triangle of awareness about lifestyle, physical activity, nutrition, monitoring of sugars, and we'll talk about that as well as insulins. The various forms are available. The most important part is the holistic team management, which will guide in that scenario. Now, often there is a lot of questions about nutrition. The key message is there is no diabetic diet in children. Anything which is healthy, they should also take, but has to be balanced. We need to use a liberal and a flexible approach. Very importantly, we don't talk about low carb diets, a normal carbohydrate intake, 50 to 55%, a reasonable amount of fat with less amount of trans fats. Of course, we want to ban them. Reasonable amount of protein and fiber is what is recommended. Very importantly, we encourage water. There is some amount of sucrose which can be taken. We don't really prefer a lot of these artificial sweeteners, and salt we have to be wary about in that regards. Reasonable physical activity, 45 to 60 minutes a day, 5 times a week. More of aerobic activities, at least 3 times vigorous activities and strengthening activities are what is recommended. However, when a child goes for a physical activity, we have to be very, very cautious in terms of the sugar levels. If they are very high, we may precipitate DKA. If they are low, we can have hypoglycemia. So monitoring of sugar, ketone, and snacks becomes absolutely important in that regards. Now, coming on to insulin, we know that insulin requirements vary with puberty. So they are much higher in puberty and then they go down post-pubertal. So typically 0.8, 1.2, and 1 is what we talk about. But everybody who is post-DKA, anybody who's managed them, know the requirement may be 2 to 2.5 unit per kg per day. And then they will come down gradually. In honeymoon phase, they can really go down to 0.2 to 0.5 unit per kg per day. Now, we all have been talking about regular insulin and NPH, which is a compromise, so to speak. Regular insulin has a time for peak to happen, and that's why you have to wait for 30 minutes to give the injection. NPH had a distinct peak, which caused nighttime hypoglycemia. So that's why the analogs were developed, rapid acting analog, immediate action, immediate going off, less risk of hypoglycemia, less post-meal hyperglycemia. Long-acting analogs like glargine, 300 glargine degludec will provide more stable care with lower risk of hypoglycemia. So we are moving more towards analogs in that perspective. The traditional split mix regimen, which included the 2 times injections of intermediate and short-acting insulin, is not something which we recommend because there is a lot of hypoglycemia and hyperglycemia which happen. So no to split mix, definitely no to premix. Premix insulins, in which you have a ratio of 30% or 25% of short and intermediate, not recommended in children, definitely in that scenario. So split mix, very, very rare scenario, but it is definitely unphysiological. What we prefer is a basal bolus regimen in which you give a long-acting insulin like glargine or degludec, and on top of that, with each meal, you give that. That's 40 to 60% ratio is usually good enough to achieve a good outcome, more flexible, better control, and you are getting insulin as far as the child is controlled, and a better response happens. Of course, the most ideal way is an insulin pump, and now we also have a closed loop system which provides you a good information, which looking at sugars and providing the corrections in that scenario. Now, when you're following up a child, very closely monitor the growth. Don't want them to become overweight, but also underweight. Look at puberty and BMI. Check for blood pressure because hypertension is very, very dangerous from a long-term perspective. Maintain a logbook. Look at the injection sites for lipohypertrophy. Check for insulin dose. Look for the glucometer and hypoglycemia. Glucose monitoring typically can be done using a self-monitoring and the logs which can be available. We look at HbA1c for chronic control, but now we are relying more often on intermittent or continuous real-time monitoring. So it's very well shown that real-time monitoring is going to help improve the control much beyond the use of insulin pump, and that you need 70% monitoring in that regards. Now, the targets for control vary from different populations, but they're generally in agreement that if you have around 70 to 126 is reasonably good for pre-meal, and 90 to 180 is good as far as post-meal levels are concerned. HbA1c cutoffs, people tend to have a different cutoffs, but if you have a low risk of hypoglycemia, go for a lower cutoff. If there is a higher risk of hypoglycemia, go for a higher cutoff. So target is less than 6.5. But if you have a risk of hypoglycemia, you can tolerate 7 or 7.5. Now, we use now CGM as a more appropriate marker of glycemic variability, and time in range above 70% is something which is quite helpful in that regards. So let's go on to some case scenarios. 7 days later, what we are seeing is that sugar readings are all right in other scenarios, but bedtime readings are going on. The child is actually on a basal bolus therapy, but the bedtime is not getting controlled. So what's the problem? The child is eating a lot at evening and we are not giving an evening snack. So if you have to give an evening insulin, you will be able to cover in that scenario. After 1 month, what you are seeing is the doses have come down and sugars are still coming down. So what's happening? This is classically a honeymoon phase, which we have to be really concerned, and you need to reduce the dose in that regards. It typically lasts 6 to 12 months, and often it's better to continue with a low dose of insulin in that scenario. After 1 month, what you're seeing again is that the readings are going up typically at lunch. All other readings are high. So what's the problem here? Is the child is getting insulin in the morning, but not in school time. So better to go for a school injection, which will provide you a better control in that scenario. Now, after 1 year, you are seeing the sugars are again going up all the way. So what it indicates is that now whatever beta cells were there, they are gone. And that's why you would need, this is honeymoon phase is really going off in that perspective, which is there. Now, follow up after 1 year, again, what you're seeing is that there are erratic readings. Sometimes the breakfast is going down up, sometimes the lunch is going up, sometimes the breakfast is going up and the dinner is going up. So what it means? It means that there is some issue in terms of either nutrition or insulin delivery. So check for lumps. If you have lipohypertrophy, your sugars will be everywhere they will be scattered in that scenario. Now, 2 years follow-up, again, the child's sugars are going down. So what's happening? Is there a second honeymoon this child is experiencing? No. In this scenario, you have to look for malabsorption, adrenal or renal or other associations which are very, very important. So we should be very careful about autoimmune associations of diabetes. Hypothyroidism is common, 3 to 8%. Ideally do a TPO and TSH at diagnosis in too early. Growth failure and hypoglycemia may point towards hypothyroidism. Celiac disease, in our experience, 10 to 14% and can happen up to 5 years of diagnosis. Very importantly, it may just be asymptomatic. You will have hypoglycemia. Do a TTG and IG at diagnosis, until 5 years of diagnosis is what is recommended. If there is a high TTG, always go for biopsy. Do not just go by TTG levels in that scenario. If somebody develops hypoglycemia and pigmentation, think of adrenal insufficiency, do a cortisol and ACTH. And of course, if there is anemia, which is megaloblastic, think of a possibility of a pernicious anemia, get a B12 level done. And that association workup is very, very important. Very importantly, you have to think of complications. So blood pressure at each visit, urinary albumin creatinine ratio annually from 11 years and typically 5 years after diagnosis. Fundus also annually from 11 years. And neuropathic screening using a vibration threshold or a vibration perception would be done. So look at these complications, because these children have to live long lives and we don't want complications to happen, and we want to manage them at the right time. Now on follow-up, this child is on insulin but very, very sick. What do we do? Whether we can stop insulin injection. There's a huge talk about inhaled insulins, but most of us are not using it because of issues in terms of flexibility, in terms of delivery. There is also issue in terms of first pass metabolism. You have to look at pulmonary functions also in that regard. What about the non-insulin options? So of the various drugs which are available for treatment, insulin, of course, is the treatment of choice for diabetes. We can think of metformin as an adjunct agent in somebody who is obese, has insulin resistance, polycystic ovarian syndrome, or non-alcoholic fatty liver disease. We can think of glucosidase inhibitors, but they are mildly effective. HbA1c fall is not more than 0.5. Interesting thing would be GLP-1 receptor analogs, which also oral forms are available. They theoretically can be helpful in obese individuals with type 1 because they will reduce the satiety, they will reduce the gastric emptying, and therefore the glucose levels will come down. SGLT2 inhibitors have been used, but there is a theoretical risk of euglycemic DKA, which may happen. So all these agents are more like sidekicks. Insulin remains the therapy of choice as far as the management is concerned. One agent which is approved in adults is amylin, but again, you have to give a lot of injections. It is mainly being considered now as a dual chamber pump where it's being used. So till now, we've been talking mostly about type 1 diabetes. What about other forms of diabetes? When should we think of other forms of diabetes? So we had a 16-year-old boy with polyuria who had hyperglycemia, very high HbA1c, ketones were high, had DKA, started on insulin, but later on was found to be obese, had type 2 diabetes in family. So everybody was happy, this is type 2 diabetes, started on metformin, sugars were normal and insulin was stopped. Now what happened 1 year later was that this child developed DKA. So is it type 1 or is it type 2? And this is a big question which we have to answer in that scenario. So as discussed, diabetes could be because of a problem in pancreas, which means there's a problem of development or damage of the pancreas, or a beta cell specific problem, which is type 1 diabetes basically, or some genetic forms in which insulin secretion is not there, or there is insulin resistance which can be congenital, which is rare in the form of lipodystrophy, or largely in the form of type 2 diabetes. So we're talking about insulin deficiency and resistance, which is a balance, and often everybody have both these components, and that makes diagnosis very difficult. So when should we think of other forms of diabetes? In type 1 diabetes, if it's before 1 year, think of neonatal diabetes. If insulin requirements are low beyond 1 year, less than 0.2, think of MODY. If they are antibody negative, also think of MODY, and if there's a strong 3-generation family history. In apparent type 2 diabetes, if there is no obesity and acanthosis, think of MODY, or a milder form of type 1 diabetes. If there is early sulfonylurea failure, think of LADA, which is a slowly progressive diabetes. If there is ketosis, again think of LADA, and fat distribution will also give you, if there is abnormal distribution, think of lipodystrophy. Now the key players you have to look at is autoimmunity and beta cell reserves. Autoimmunity are the best predictors. So at early stage of disease, look at autoimmunity. Beta cell reserve, which is C-peptide, it's late stage of disease. So early in disease is autoimmunity. You can look at GAD, or ZNPT, zinc transporter, or IA2, or latent disease, you can look at C-peptide. So how do you classify diabetes? If you have any age of onset with less answer of family history, with severe presentation, ketosis being present, and you have autoimmunity in the form of GAD antibodies and low C-peptide, you're talking about type 1 diabetes. Pubertal onset with obesity, you may have mild ketosis, but GAD negative, think of type 2. Very importantly, you have to do autoimmunity before you make a diagnosis in that scenario. And of course, if you are thinking of MODY, in that scenario, there is a strong family history, which is there, we'll identify. So looking at GAD and C-peptide, you can make the diagnosis in that scenario. Very importantly, if the GAD is positive in type 2, there is lower beta cell reserve, less metabolic features, and insulin will be required. So to classify diabetes, onset before 6 months, think of neonatal form. After 6 months, DKA present, yes, and you need insulin, this is type 1. Don't worry about this. If you do not need insulin, get GAD antibody. If GAD antibody is positive, this is type 1. Negative, go for genetic studies. If you have no DKA at presentation and you are obese also, still do a GAD antibody. If GAD is positive, this is type 1 diabetes. Negative, and there is no obesity, this is MODY. If there is obesity, it is type 2 diabetes. So age less than 6 months, more than 6 months, DKA present, continued requirement type 1, DKA absent but GAD positive type 1, DKA absent, GAD negative, obese type 2, DKA absent, GAD negative, or low insulin requirement, think of a genetic cause. So this is the algorithm which can really help you out in classifying diabetes. And what we've also done is to develop a diabetes interpreter, which basically looks at these parameters, basically the gender, the age, the date of diagnosis. And what we did was that based upon these parameters, we tried to classify 247 children who presented in the last 2 years in our clinic. And what we found interestingly was that there was a 98.7% concordance with the apt diagnosis and the actual diagnosis. And this is one which reduced the amount of genetic studies and a lot of other complications. So we have developed a simplified low-cost algorithm which reduces the need for genetic testing and GAD testing. And this is one being presented in ISPAT by one of our fellows, Dr. Pratik, as an oral presentation in Abu Dhabi soon. So this is something which is interesting. So all of you can go and have a look at our website along with our mobile application, which we have tried to give evidence-based management in that regard. So I'll, at the end, thank the entire team of Dubai Pediatric Club, in particularly Dr. Saurabh, Dr. Kalpana, and Dr. Diary for inviting me for this discussion. And I'm just sorry to overextend because it was a very big topic covering these 3 large topics, but hopefully we can cover on various aspects as well on the discussion part. Thank you.
Thank you very much, Dr. Anurag. This was a very teaching session, not only for pediatricians, for residents, for fellows in pediatric endocrinology. Thank you very much. Now I would like to request Dr. Asma, Dr. Nando to join us in the panel. I would like to request Dr. Kalpana to start the session.
Yeah.
Dr. Diari will join us later. Now, one point I want to add, that diabetes is so important. 5 Nobel Prizes are given only for diabetes. And our Dr. Anurag mentioned, Dr. Asma is a president of International Society of Pediatric and Adolescent Diabetes. They're having a conference from 13 to 16 October in Abu Dhabi. Requested to go to the site and register. So Dr. Kalpana, over to you. Start the session, please.
Thank you, Dr. Saurabh. First and foremost, I must thank Dr. Anurag. It was a very exhaustive presentation, but you have simplified the topics a lot. The approaches have been clarified. So thanks a lot for that. And I would like to start by asking questions on DST first. So, you know, what are your opinions on what is the most important in DST not to miss? I mean, I'm sure the salt wasting, which can be life-threatening, is like if we see a child, a neonate, for example. So what are your thoughts on this, Dr. Bajpai?
Yes, I think that's very, very important. So if you have a child with DSD, particularly with a non-palpable gonad, and this is a very big message, non-palpable gonad, even if you have a normal male appearance, can still be a salt wasting form of 21 hydroxylase deficiency. So you have to think of a salt wasting form. So 3 days later, you can get a 17 OHP level done. That is very important because salt wasting will happen around 2 weeks of life. That is a typical scenario. Now, rarer male forms of CAH also we need to be aware of. So if you have a XY DSD also, there could be a 3 beta HSD or a star defect or a side chain cleavage defect. They can also have salt wasting. So you have to monitor their electrolytes in that scenario very well. The second big thing which you don't want to miss is the risk of gonadoblastoma, which may develop over time. So if you have a XY line or if you have a XY DSD, quote unquote, and you have an abdominal gonad, explore and remove. That's a very, very urgent message which is there. If there is a steroidogenic defect and if you have an abdominal gonad, remove it. If it's an inguinal, still you can bring it down to orchidopexy. And if it's high up, you can bring it down and monitor. But I would say the second big thing, of course, is with regards to the immediate issues of salt wasting and the risk of malignancy. Of course, very important, of course, which I didn't go into because of the lack of time, is the social issues as to how we can explain, how we need to be non-committal, how we need to involve the family. And there's a lot of debate about gender of rearing because we didn't go into all that debate about what will be the appropriate. So I did put it for the panel because I didn't want to create confusion there.
Yeah, sure.
Time, but all these issues are very important.
Yeah. Yeah, in fact, that is what I would like, Dr. Nandu. Could you please comment on this? Like, we see a neonate and we suspect DSD. How cautious should we be? You know, because obviously before it takes time to come to the final diagnosis. So as regards the gender declaration is concerned, what our approach should be at that point?
I think if at all possible, you should avoid committing to sex until you have the data. Now sometimes, you know, there may be palpable gonads, so in which case it's clear that it's a male infant. I would say that if you can get a reliable ultrasound done early and see if there's a uterus or not, that will be enormously helpful. But you have to have a competent radiologist, and even experienced radiologists can occasionally miss that uterus because it does tend to be somewhat involuted because of the androgen exposure in CAH. So I have seen several times over the years cases where that uterus was not thought to be a uterus, and so we've sort of slightly gone down the wrong track initially. But FISH for Y chromosome, which Dr. Anurag mentioned, will normally give us a result within 72 hours, confirming either male or female. So if you've got a female with DSD, then really it's going to be CAH or something like it, unless the mother has been exposed to androgens in pregnancy, which is rather uncommon nowadays, thank goodness.
Right. And Dr. Asma, do you think it is important for us to really document in detail the initial appearance? Would that have a bearing in future? How important is it?
Thank you very much. Before I speak, I just would like to congratulate Dr. Vajpayee. I don't know how you managed to do it. I mean, in less than an hour, you talked about most of the endocrinology, something that we do over years. It's a textbook, what you have given us, not just a talk. Okay, so if I understood correctly, you said, what's this importance of documenting the phenotype on the newborn period? Is that the question?
I think yes.
Okay, all right. I think that is critical. Despite the fact that we do not want to lose life-threatening conditions like the salt wasting, the phenotype is incredibly important. And whether regardless of what the gender is going to be decided, the phenotype has a critical role because it's one of the criteria on how to go when it comes to gender assignment. So yes, we know that the diagnosis is important. Yes, we know the karyotype is important. We know that the hormone profile is important, but again, the phenotype is important. And that's where the role of our surgical colleagues come, because it's easy to resect the part of the phallus, and it's easy to remove the gonads. It's easy to correct hypospadia, and it's easy to amend the genitalia and genitoplasty. But constructing a male penis is something that's next to impossible. So involving our colleagues of pediatric surgery on their comment and ability to operate on that particular genital form or phenotype is of critical importance, yes.
Dr. Kalpana is mute. Dr. Kalpana, Dr. Diari will join us later. What are the cases which require surgery? I mean, all panelists, I would like to, Dr. Kalpana, please. I thought you are not there. This question I asked whether which type of these cases require surgery and involvement of pediatric surgeon.
Yeah. Sure, we can have the answer on that and then we'll move forward.
Yeah, I think that's a very, very important question. And this is a very, very debatable issue, because even in India now, certain states are saying that we need to have a legal permission before you go ahead with any of the gender surgeries, because it's a lot of debate as to what is the right time to do surgery. Earlier, people used to be very aggressive. I remember when I was in Melbourne, Professor John Hudson's group was very aggressive initially in terms of early clitoroplasty, especially for 21-hydroxylase deficiency, and a lot of other factors were going on there. But now, as Dr. Nandu said, we need to be very cautious. We need to keep a lot of decisions in that regards. And then we can move forward once a proper informed decision is taken, even at a later age group. Often legal angles are also involved. But if I put it in a very broad perspective, if you have a case which looks like classically a 21-hydroxylase deficiency, and you have got clitoromegaly, labial scrotal fusion, definitely you will need to go for a genital surgery at some point of time. That is one scenario which is there. We do see very late presentations of CAH, which are presenting around 10 to 12 years of age, absolutely male, as I showed that 11-hydroxylase deficiency, who have got a normal male who may sometimes present to you with cyclical hematuria. There you can't change their gender, but you have to remove the uterus, you have to remove their breast tissue and all those things that might be required in that scenario. So it is required, but it has to be a decision which is shared between the patient, very importantly. Now this message is coming up from a lot of groups, as well as the parents and family. I'll maybe like to have opinion from Dr. Nandu and Dr. Asma as well on that.
Well, I agree with you, particularly about boys who've been exposed to, or XY individuals who've been exposed to testosterone in utero, because, I mean, unless they don't have functioning androgen receptors, and so therefore haven't functionally had testosterone exposure, they're much better off being brought up as boys, if at all possible. And there were several infamous cases in the past of gender assignment as girls, of individuals who then became very unhappy, felt they were trapped in the wrong body and so on as they grew up. And this led to patient groups setting up, and really led to a whole raft of things, including the nomenclature we use now, the DSD nomenclature instead of the old ambiguous genitalia, and also to the delayed surgery, because actually you don't have to do the clitoroplasty at an early age, but you will have to create a urethra. Otherwise, this girl, for example, with 21-hydroxylase deficiency is not going to be able to be continent because she'll have a urogenital sinus. So I think there are some things you have to do surgically at a relatively early age, but some surgery doesn't have to be done that has historically been done. So, for example, it was my experience as a trainee 30 years ago, that it was very common for children to have or girls to have the clitoroplasty, and then vaginal dilatation, which was given daily or administered daily, but usually by their mothers. And this is very traumatic and psychologically harmful, really. And there's no need for that. You can wait until the girl is in puberty and do the vaginal dilatation at that point in time when she's of an age to understand what is happening to her. So I think there aren't, this is the whole thing is a minefield. We haven't even touched on the issues of sexuality and gender identity and so on. So I'll let Dr. Asma answer those questions.
Yeah, I think I can't agree more. I'm really glad that DSD was chosen, because DSD is not only endocrinology. When we talk DSD, we are talking about psychology, we are talking about patient advocacy, we're talking about science, embryology, religion, culture, patient choice, and so on and so forth. What Nando was talking about was perhaps related to cases where people don't know where to go, but even when the condition in DSD is well defined, let's say a little girl who is diagnosed with classical CAH, still the debate persists. So if you've completed the diagnosis and there's no ambiguity anymore in the diagnosis, there's still an issue about whether to operate early or late. Now, patient advocacy and patient advocates have been pressing very hard on this issue. And I remember in one of ESPE, European Society of Pediatric Endocrinology, meetings where there was a crowd of these patient advocates in front of the conference door saying, leave patients alone. And there has been lots of long-term studies which showed patient dissatisfaction with early surgery because of adhesion and adverse effects on their sexual satisfaction because of early intervention due to adhesions. And so it's not only that surgeons want to make genitalia look more natural, there is a lot more to think about in this regard, hugely complex.
Absolutely. So in regards to 21 hydroxylase deficiency, Dr. Anurag, you mentioned that the 17 OHP level is very high in the chart, very high, and the next one is high. So what is the cutoff when we say very high?
So generally, if we talk about nanogram per ml, we're talking about 100 nanogram per ml. In nanomole per liter, it will be like 300 would be the one, 10,000 nanogram per dl. That will be the typical cutoff which we'll see. What is important to remember that we need to have an extracted sample, and often the EIA-based assays, the immunoassays may not be reliable in this period. So sometimes we may think of a GCMS-based assays. In conditions like 11 hydroxylase deficiency and 3-beta HSD, you can have mild elevation. So if you talk about normal, being around 2 to 3, they may go up to 10 to 20 sometimes. But if it goes beyond 30 to 100, we are talking about classical 21 hydroxylase deficiency in that scenario.
Okay, I'm sorry to ask, but what is GCMS? Because some short forms
GCMS
we are not familiar.
So GCMS is basically a structured based assay, which is gas chromatography along with mass spectroscopy. So this is more like structure, while immunoassays are looking at specific epitopes. So there are similar steroids which are being produced by the fetal adrenals, which causes confusion in estimation in immunoassays. So often, if there is doubt, we go for GCMS, the structured based assays.
Okay.
It's very treacherous, actually, the fetal steroids, because they persist really up until 3 months of age, or even longer, 3 months of corrected age if you're dealing with a premature infant. And they really make it difficult to interpret sometimes in borderline cases.
Right. Dr. Nandu, I would like to ask you, which are the cases of DST or clinical scenarios, so to say, that in older children we should think about it? If you can just list a few.
Well, I think Dr. Anurag actually covered these really. I mean, so you might have the girl presenting with apparent primary amenorrhea, who's actually 46 XY, typically with complete androgen insensitivity, but less commonly can be 5-alpha reductase deficiency also. So in this situation, the girl has breast development because the testosterone that they make is aromatized to estrogen. So they have breast tissue. They will have rather sparse pubic hair, body hair, but there is no uterus, so they're not going to have menses. And often they're rather tall. You know, they're obviously having XY chromosomes. They tend to be taller than most girls of their age. Other situation, as Dr. Anurag mentioned, the child with the male child with undiagnosed CAH. Actually, there's a lot more females diagnosed with CAH than males, so we're clearly missing quite a few of them. And the male child with CAH, the female child presenting with very virilized CAH could be mistaken for a boy and presents late, but there are no testes. So eventually this will be picked up. You know, the child will virilize because they're making androgens, but maybe they're short because actually they're XX. However, there are no testes. So then you could potentially, as Dr. Anurag says, you typically see these boys around 10 to 12 years of age when things aren't quite as they should be and breast development is starting. So then you have to go in and that's a very difficult situation to unpick, I have to say, a very difficult situation indeed. I mean, I think the most important thing in that situation is to be very sensitive. And you don't ever say to the child, oh, you're a girl, really, because obviously their gender identity and sexuality has been established. Well, certainly gender identity has been established by then, and it can be really profoundly shocking to a child to be, you know, if they're told, oh, you're actually a girl. You don't say that. You say there's a chromosomal imbalance. You have a difference in your chromosomes, which means that things haven't developed quite as they should have, and therefore we will need to give you some treatment. And you know, this is a very difficult scenario that I hope to you know, not see too often. And there can be other situations which are sort of analogous. You know, girls presenting with Mayer-Rokitansky who just don't have a uterus, even though they have ovaries. And so, but this late presentation of sexual identity or sexual phenotype is a very difficult scenario. So I think you can think of various situations that may arise, but essentially it has to be tackled with great sensitivity and kindness.
Sure. So in relation to this, Dr. Anurag, the case that you presented of a 10-year-old girl with clitoral enlargement, you know, she was being raised as a girl, and then you said that the diagnosis would be 5-alpha reductase in that case and should be male gender assigned. So this poses an ethical, moral, or I don't know, social dilemma for the parents, for the doctor. So how do you all deal with this? Have you had to, you know, deal with such cases, and what is then done?
This is a very, very difficult scenario. In fact, the 5-alpha reductase, which is actually reared as female, and then they are having this virilization, which is happening typically around 10-year, 12-year, when the testis is increasing testosterone levels, which are bypassing 5-alpha reductase and acting directly to cause that. Now, we recently had a similar case scenario, and in fact, in that case, there was some clitoromegaly to begin with. So it was a bit of a doubt which was there in mother's mind even in the beginning. And now there was a change in behavior of the child also. So what they said that this, while we are having this clitoromegaly and other changes, virilization, which is happening, there is also a change in more male behaviors. And the child was more comfortable as a boy, although she was raised as a girl. So it was a very, very difficult scenario we had to discuss in detail. But at the end, they also agreed that given the overall child's, we had a psychological assessment as well, which was more like a male gender affairing. They actually had to relocate to a different place, got to a different school. So it was a lot of social issues which are also involved, because you can't just, they're coming from a village where everybody knows them. So they can't just change it right away. So it was a very complicated scenario that go to a different city, different school. But then finally, so it was more like a combined decision, including the child and the family, the psychologist and us and the pediatric surgeon. So it has to be a team effort. The message here is that don't try to push. It's not going to be a dictatorial, paternalistic attitude which is going to work. It's more likely to be discussing sort of a democratic setup, which will be much more important, with the most important factors being the child and the family. That's what would be there. But it's a very, very difficult scenario, and we don't want to get into that very often because it's a very, very cumbersome process, I would say.
Right. So, Dr. Saurabh, do you have any specific question regarding DST?
I think if we move to other parts, more questions are hypoglycemia, diabetes.
Yes. Yes. So we'll move on to hypoglycemia, though again in hypoglycemia, I think Dr. Anurag did a fantastic job and, has clarified most of the things. There was a question from Dr. Varsha, if I can just go to that. Basically, the thing was that she says that in clinical pediatric sepsis scenario or acutely sick children, very often we come across cases of hyperglycemia. What should be our approach there then, which is related to the acute stress, or how do we differentiate it from diabetes? So Dr. Anurag, if you can clarify that.
So stress-induced hyperglycemia is something which is pretty common, and this is often encountered. Often it is temporary, but we need to be very, very wary that this could actually be the first manifestation of type 1 diabetes. So if your sugars are persistently high beyond 200 milligram per DL, if there is infection, we might consider a short course of insulin infusion. If the child is on steroids, then the likelihood of having type 1 becomes less. But otherwise, we will definitely get a GAD antibody done, because this could be a covert diabetes which manifested for the first time during stress. So in nutshell, if there is a steroid-induced hyperglycemia, the management is slightly different. If you have no drug which is causing hyperglycemia, still hyperglycemia was there, even if it is transient, be wary. This child may develop type 1 diabetes later on. That becomes important. A very interesting scenario could be that you have a sick child who has hyperglycemia and variable sugars and ketoacidosis. This could be a presentation of organic acidemia, which also we need to be wary about, which we didn't discuss in the differential. But yes, if your sugars are not very high, but you have ketoacidosis, 200, 250, and then on insulin becomes hypoglycemic, organic acidemia, many of them are really mimicking DKA as a possibility as well.
I've seen, so particularly in respiratory cases, we see the stress hypoglycemia, severe asthma, which is then treated with steroids, but also the salbutamol itself is both stimulatory to glucose production and to ketogenesis, actually. So I've even seen salbutamol-induced ketoacidosis. But a useful tool actually is the HbA1c. Because if the HbA1c is very normal, 5.2% or something, then really it's extremely unlikely that this is new onset diabetes. It could, however, be, as Dr. Anurag said, that diabetes is on the way, and therefore I would also measure antibodies just in case, because you don't want to see that child coming back in 3 months' time with new onset diabetes that you could have picked up at an earlier stage.
Right. And also in acute situations, very commonly we see hypoglycemia. So would it be important to collect a critical sample in each and every case of hypoglycemia that we see? Or is it in cases of resistant hypoglycemia or those requiring higher, glucose administration rate. So what would you say to that?
Yeah, so if you have a neonate, as I discussed, that if you have hypoglycemia in the first 48 hours, that is not considered to be significant. If it's persisting beyond 48 hours, or if you have classical features, clinical clues, you have macrosomia, you have features of hyperinsulinism, features of Beckwith-Wiedemann, you are concerned. But beyond 48 hours, if anybody is developing hypoglycemia, I will be very, very wary. Because in illness, you will be less likely to develop hypoglycemia unless there is something going wrong. So I would like to definitely work up anybody beyond 48 hours, even if it is in the setting of an illness. Because remember, fatty acid oxidation defect may present only during illness. Many of these milder hyperinsulinism forms, which we didn't discuss a lot, may present during illness. So in illness and cortisol deficiency, we often see, especially if there is an isolated cortisol deficiency like a AAA syndrome, or some of those steroidogenic defects in which only the glucocorticoid is more affected, or ACTH resistance, you will mainly present with hypoglycemia during illness. So I would say that just because you have got some sickness, you should not develop hypoglycemia. There is a very robust mechanism to protect hypoglycemia. If you have hypoglycemia during illness, you should first exclude all other causes, and then you can say, okay, now I want to attribute it to illness. That will be very less likely.
Okay. What would be practical advice to parents of children with ketotic hypoglycemia? Because sometimes we see them coming back, a couple of times with a similar situation and getting admitted. So as far as their feeding is concerned, Dr. Asma?
Yeah, thank you. I mean, all questions were very interesting. And just prior to go and answer the ketotic hypoglycemia, another very important scenario is the acute abdomen. Appendicitis in particular. We see children who come in with abdominal pain, have been vomiting, so they will have ketosis, and they can be easily confused with diabetes ketoacidosis and vice versa. So there are many children who, it can be both ways. So children with genuine acute appendicitis has been diagnosed as DKA and didn't have surgery, and the other way around. DKA children can be confused with appendicitis and can go for appendectomy. So we work hand by hand, endocrinologists and general pediatricians, definitely. Very interesting stuff. Ketotic hypoglycemia, it's, I mean, Dr. Bajpayee very importantly highlighted to a point that it's a diagnosis of exclusion. And I must admit that I remain a little bit uncomfortable about the diagnosis. And I feel these children need to be extensively investigated, because sometimes you have all the criteria fitting ketotic hypoglycemia, but small for gestational age. But again, we see it in some children who are of normal weight. But anyway, directly back to your question, what do you advise parents? Very clearly from the talk we have heard, avoid fasting for a long time. And some children, they do not tolerate a long fast. And the commonest reason for fasting in children is sleep. So if these children, if a child had an early dinner and then slept and didn't wake up early morning, then this is a clear trigger for hypoglycemia, ketotic hypoglycemia. And I still remember 25 years ago during my training, when parents put a little bit of starch in some water and give it to these poor children. It tastes horribly.
Horrible.
But more currently, there are lots of complex carbs that these children can have. There are glucerna bars and other stuff which consists of fibers. So in a summary, avoid prolonged fast, or if the child is likely to sleep in the morning, then giving him or her a bit of complex carb prior to sleep. That can help preventing the episode of hypo. Thank you.
And what is the long-term prognosis of these children with ketotic hypoglycemia?
Generally they do well.
They do well.
Yeah, but there are situations where the ketotic hypoglycemia can come back. So the teenager who goes out and drinks lots of alcohol, then he's at much higher risk of hypoglycemia again. And similarly, well, it's a different context. Pregnant women with hyperemesis are at risk of ketotic hypoglycemia. So it can actually manifest even in adults, the ketotic hypoglycemia. So it doesn't go away completely. You keep the risk, but your chance of becoming hypoglycemic becomes much less, because as Dr. Anurag said, as you get older, so your glucose reserves become greater, your liver is bigger, so you can manage for longer. 48 hours in an adult is quite common before you start to show signs of hypoglycemia.
Right. There's a question from Dr. Hebella asking, what about protein challenging tests for congenital hyperinsulinism? Dr. Anurag?
Yeah, so this is basically for what is known as earlier known as protein sensitive or leucine sensitive hypoglycemia, which is basically because of if you give too much protein, they've got more activity of the GADPH channel in that enzyme which causes this hyperglycemia, which we would not be doing routinely now in the clinical practice because it was a more risk. These individuals do not often have that severe hypoglycemia. They have milder form of hyperinsulinism. If they get a lot of carbohydrate or leucine in particular, they will develop hypoglycemia. Often ammonia levels are high in that scenario, so that could be a clue. But better to go for a genetic test. We do not do routinely this protein challenge test. Your opinion, Dr. Nandu and Dr. Asma, on that?
I agree. I've never done.
I can't agree more. Yeah.
I think nesidioblastosis was fading out of memory even when I was a medical student. Yeah. So.
Dr. Kalpana is mute. I think if we move on more important topic of diabetes, actually diabetes mellitus come from two words. Diabetes means to siphon, mellitus means honey. Initially they thought that these people, they are passing honey. They used to diagnose, they used to, make them stand and pass urine. Where the ants were there, this was the method of diagnosis in old age. And you know the history of that Banting and Best $1 they took and they made it, not to be patented. Dr. Kalpana, because if you are not there, I'm giving some historical background. I think better to go to diabetes, but the more important topic. And now, again, I mentioned Dr. Asma is the president of International Society of Pediatric and Adolescent Diabetes. The conference should be held in Abu Dhabi on 13 to 16 October, so all are invited.
Sure. So as far as diabetes is concerned, every time we have a talk on diabetes, we ask the same question: are we closer to a cure? So maybe Dr. Asma can enlighten us on this.
I don't think that I caught the question. If you don't mind repeating the question, apologies.
I'm saying about what is new. Are we coming close to curing it? Are there any, as far as the treatment modalities are concerned?
All right, that's brilliant. This is a very interesting question, particularly when it comes to type 1 diabetes, because we are still treating type 1 diabetes with insulin. And I remember a very interesting comment from a father one day when his son was diagnosed with type 1 diabetes, and I was sitting counseling him about starting insulin. And he was very frustrated and said, Dr. Deeb, you've been using insulin now, or people have been using insulin for more than a century now. Did you not find a treatment for this? So it's a very valid question, what you are asking, because as you all know, insulin use started back in early 20s, and now we are over 100 years and we are still using insulin. Now there are three modalities for the promising new treatment. The first modality is technology. At the moment, we are using advanced hybrid loop insulin pumps. Again, it's not a closed loop. It still requires patient's intervention. So that's one way of treatment. The other area of treatment is the area of transplant. So islet cell transplant or stem cell transplant. And again, I would like to use this platform to convey a very important message here. The stem cell transplant, while it's very promising scientifically, it's still not at a stage of clinical use, because many people took their children all over the world and spend a lot of money when it's not actually a confirmed and applicable treatment clinically, only promising. And the third aspect, so we have technology, then we have the transplant, and then the third part is the immunotherapy. So that there's lots of studies and work in the literature about this third way. Sadly, we haven't got any of these completely available for our children with diabetes to use. There's a lot of work in each of these three arms, but apart from the advanced technology and the latest 780G pump, for example, there isn't anything that's concrete to cure diabetes.
Right.
I like to quote my professor, Dr. George Werther, who was in Melbourne. He used to say that from 80s, when he joined, he was always say 10 years we will have a cure. But in 90s, they said again 10 years there will be a cure. So the same cycle is continuing. We are not really, cure is something which is there, but there's been a dramatic change in the way they are managing. We are managing children from syringes, from the NPH and regular, from premixes to the 780G. There's a huge change. So there is a dramatic change in the level of care which is there, level of monitoring, complications have come down, but cure is a distant thing. Now, what we will define as cure is also something which you might have to question in that, but probably we are not in the, technology is the way forward, I would say at the moment, rather than the other solutions.
And as regards the current treatment scenarios are concerned, there were two questions. One, regarding the premixes, you said they are not to be used, and if I remember right, it's because they are not physiological. They say that they are being used in adults, so why not in children? Number one. And what is the role of SGLT inhibitors in children? So in type 1 diabetes.
Yeah. So premix insulin, you want me to answer?
Yes, please go ahead.
Yeah, so premix insulin definitely the very unphysiological form. You're having a ratio of a short and long acting insulin. You can't change one over the other. So if your sugars, let's say post meal is high and pre-meal is low, you can't change the value together. You are fixed at a 30% ratio. You have got an insulin which is acting for 12 hours. You will have hypoglycemias in the midtime, nighttime hypoglycemias. You will have a high level which will happen post-meal. So it is going to cause a lot of confusion, a lot of chaos, so to speak. Now, while we are saying it is used in adults, it is also not the appropriate way of treating adults. So we are actually saying that there also it's not a physiological way. Now, why they're using it's probably we are not going to interfere there, but at least in the arena of pediatric and adolescent, this is going to cause even more complications because children do have a very, very erratic meal pattern, physical activity. So I would say in this day and age, basal bolus is the basic therapy which every child with type 1 diabetes would deserve. If there is some issue, then split mix maybe, pre-mix definitely is not justifiable from any perspective. Now, coming on the second aspect about SGLT2 inhibitors, as I had mentioned in one of the slides, the role is limited mainly in terms of reducing weight. So people have used in overweight individuals, some reduction in weight, some reduction in insulin dose, some reduction in HbA1c. There is a theoretical risk of euglycemic diabetic ketoacidosis because your glucose is coming down, but your insulin deficiency is persisting. So you have to be cautious. So at the moment, less than 18 years, definitely not recommended. This is an area which will be washed out. I would say GLP-1 receptor analogs may be better off than SGLT2 inhibitors in a long run, especially in obese type 1s, because they will reduce your satiety, they will reduce your gastric emptying, they will have a glucagon effect as well. But still, we have to be cautious. So less than 18 years, I would say we are not going to use any metformin. As I said, PCOS, NAFLD, very obese. Metformin is probably safer beyond 12 years. We tend to use more common, but other drugs, very, very cautious, I would say.
The only thing I would add to what you said is that the SGLT2 inhibitors do appear to have marvelous renal protection.
Yes.
I mean, they're actually now used for renal disease on its own without diabetes.
Cardiac, yeah, renal cardiac.
That's heart disease too. So, and these are the big killers of people with type 1 diabetes, particularly if they've had poor control. So I think it may well be the case that when we're seeing diabetic nephropathy appearing, which we often do in the teenage years, that perhaps this, rather than ACE inhibitors or ARBs, that we'll be going to SGLT2 inhibitors in these patients. But it's absolutely critical to use a super long-acting insulin like Degludec or Toujeo to suppress the ketosis because they all become ketotic to some minor degree. And if that's combined with non-adherence to insulin therapy, that's a very high-risk situation.
Right. Dr. Anurag, you presented a case of DKA with AKI. There's a question regarding that where they want to know how do we know the acidosis is because of kidney injury or because of DKA, and in such cases can we use bicarb, soda bicarb?
Yeah, so this is a very interesting question. Now, subclinical acute kidney injury is very, very common in DKA. If we actually measure creatinine levels, and many people say 20%, 40% as well, but whether that's clinically relevant is of course a big question. But definitely overt kidney injury is also common, especially if you have rhabdomyolysis, hypokalemia in that scenario. Now, how do you really differentiate whether this acidosis is because of DKA, renal injury, hyperchloremia? So I said, first thing, of course, would be ketones. If your ketones are low and your acidosis is persisting, it's not because of DKA primarily. Second would be your lactate. If your lactate is normal, that again will be making infection, other possibility is less likely. So in that scenario, if you have a rising creatinine, if you have oliguria, if your ketones are better, you are later in terms of disease when the disease is becoming better, but your acidosis is increasing suddenly, I'll think of an AKI in that scenario. And I would say bicarbonate plus minus, but I would be very, very rushing towards dialysis, because I've seen that if you delay dialysis in that scenario, it is going to cause a havoc because you're giving too much fluid, body is not able to pump it out, and suddenly you develop cerebral edema, cardiac ARDS, and all those pulmonary edema and all those features develop very quickly. So I would say bicarbonate still plus minus, but probably go for, because this acidosis will not be very severe to kill the child immediately. Go more for dialysis. Early dialysis will be what I'll prefer in that scenario. An established AKI. Of course, you exclude pre-renal forms, you give fluid boluses and all those things. Mild AKI is very, very common, which may happen, which we are not monitoring often in many scenarios as well.
Right. And you mentioned that there is a chance of rhabdomyolysis in some cases. So how common is this,
We have seen many cases whose pH is below 6.9. Usually we do see hypophosphatemia very significantly. And what we have seen is that a couple of those cases actually went on to rhabdomyolysis and kidney injuries. And then once we corrected their phosphorus well, so from there on, we were very cautious. And once we are able to correct that phosphorus, we have not seen, even in those very severe cases. So what I'll say is that if pH is less than 6.9, even less than 7, be very cautious about phosphorus and give potassium phosphate 50%. There are recommendations. Some people do it routinely in everybody. But in our scenario, we tend to use it when the pH is, it's very, very severe metabolic acidosis. So it is a definite entity. It may be subclinical and suddenly your creatinine will jump up. That is an important message.
So is potassium phosphate easily available?
Yes, it's easily available now. Yeah, the cost is a bit more, but now it's, earlier it was not available in India, but now it's easily available.
Okay.
Yes, we use potassium phosphate and potassium chloride 50-50. It's standard now.
Okay.
Yeah, we do the same as well.
And just to clarify, the very initial fluid bolus, has it not been reduced to 10 ml per kg now for DK?
Yeah.
Depends on the
Because you
severity.
mentioned 10 to 20, so I just wanted to be sure
It's
on that.
generally 10 ml per kg, but if somebody is in a significant under hypovolemia, tachycardia, dehydration, hypotension, you can give more boluses. So 10 to 20, that's what it's recommended in that scenario. If somebody is in shock, which is very, very rare in DK, you can go even faster. Like the latest ISPAC guidelines talk about 20 to 30 minutes at the time, but in shock, you can give more quickly.
Okay. So I think we have covered most of the questions asked.
Question that I wanted to request. I would like
Yes.
to tell the viewers that in the last session we had face-to-face, Dr. Anwar presented how to use growth chart. Now I want to request him in few slides, just because now, I mean, we are having all the viewers from many countries. Just in few slides, please.
Doctor, just one question before that. There is one
Yes.
Dr. Reena Kurin. She has asked about screening of siblings of children with type 1 diabetes. So if you can just touch upon that before you go for the growth charts.
Okay, so maybe Dr. Asma, you like to take on that? Whether sibling screening routine you like to.
Yeah, I mean, I don't mind. We all know that type 1 diabetes is not a hereditary disease. It's neither monogenic nor it's an autoimmune disease. And yes, there is a higher risk of siblings. There's lots of twin studies in particular, which show that the incidence is quite high, particularly in identical twins. So if one twin develop diabetes, then the other identical twin is very likely to develop. I think it hits around 90%, if I'm not mistaken. But without citing any scientific reference here, and if you excuse me, put down here my personal experience, I don't think it's worth screening siblings in type 1 diabetes. The chance of getting some positive tests will just increase the worry from the parents. We do not have treatment for those children. I mean, the definition of a good screening test is if you diagnose the disease early, then you do something about it and you prevent complications. And yes, one might argue it might prevent diabetes ketoacidosis, but again, I wouldn't screen siblings unless the parents really pushed me very hard.
The only thing is it may change in the future because we have a new drug called teplizumab, which may be approved later this year in the US, which has been shown to greatly delay the onset of diabetes in antibody positive individuals. So if we have a potential treatment, then that will potentially change the game. And it may then be worth actually looking at siblings who are definitely a much higher risk than the background population.
Is that a monoclonal antibody, doctor?
Yes.
Okay. Fine. So move on to the growth charts.
Yeah, growth chart, Dr. Anwar. Because
Yes,
it was really good that now we have many viewers, so for the benefit of that.
So yeah, so Dr. Saurabh, we'll just go, I think, couple of slides only just to highlight the key aspects. So when you look at growth chart, there are three things to look at. One is what is the absolute status of the height of that child, and how do you look at? You basically compare that using a percentile, which will give you the ranking of the child in that scenario, or more specifically look at standard deviation score, which will give you an exact scenario about the current height in that regards. Then you compare this to parental expectations. In that scenario, you look at the target height, which basically we all know how do we calculate from mother's and father's height, and adds 13 centimeters for boy divided by 2 and minus 13 centimeters for girl. And we can also use target height standard deviation score, which is a much better way of expressing Generally, a child should be within 1.5 standard deviation score of the target height, and this is something which is important in that regards. So if somebody's corrected height standard deviation score is within 1.5, it is familial. Otherwise, you are dealing more likely with a scenario which is non-familial short stature. The third important thing is to look at the impact of nutrition. And when we talk about short stature, we're usually talking about endocrine versus a nutritional cause. In endocrine, you have a predominant effect on the height. In nutritional, you have a predominant effect on the weight. So what we look at is the height and weightage. If you have a predominant effect, weight is more affected. This is nutritional. Height is more affected. This is endocrine. And finally, this we can also use using BMI standard deviation score. So if your BMI standard deviation score is less than -1, this suggests more like a scenario of endocrine of a nutritional cause. If it's more than -1 standard deviation, this is more like a endocrine parameters. We've also developed a growth interpreter, which basically once you feed those data, you will get the appropriate plotting and the likely diagnosis in that scenario. So we'll go to a couple of cases. 12-year-old girl, height is 120 and weight is 15 kilograms. Now, hemoglobin was slightly low. TSH and TTG was normal. This child was evaluated for growth hormone by the treating physician. IGF-1 was low and the basal growth hormone was low. Now, if you look at the chart, what you're seeing here basically is that there is a much more effect as far as weight is concerned than the height. So this child is short for the population, but the weight is more affected. Now, what this means is that this is most likely a nutritional form of growth failure. And if you really analyze the overall scenario, it is nutritional form. So what we are seeing in malnutrition, IGF-1 can be falsely low, and basal growth hormone, of course, has no value. So this child actually is not growth hormone deficiency, turned out to be a IgA deficiency, and that's why there was a falsely negative TTG level. So the message here is that you look at growth chart first before you really go ahead in terms of evaluation. Second scenario, a child whose height is 100 and weight is 18 kgs, delayed bone age, TTG was found to be borderline 32. And what it was suggested in that scenario is that TTG is borderline high, let's start gluten-free diet, even without a biopsy. Now, what happened, of course, was not unexpected. There was no response to gluten-free diet. But if you look at the chart, this child is short for the population, short for the family. But what is more affected? Is it the height or the weight? So what we see clearly here is that height is substantially more affected as compared to weight. So this is a classical endocrine pattern of growth failure. And this falsely high TTG, unless it is documented, if the TTG is 10 times or less increased above the baseline, we don't diagnose celiac, you have to do a biopsy. And this child classically has an endocrine pattern growth failure. And best in that scenario, BMI SDS, as I said, is more than -1. This suggests endocrine cause. In that scenario, you should do a growth hormone stimulation, which was there. So the most important thing to look at in a short child is the weight, not the height. Weight more affected is nutritional, weight less affected and height more affected is more like an endocrine cause. Coming on to the obesity part, 12-year-old girl, height is 130, weight is 58. The screening tests were normal, reassured that presented with rapid weight gain. Now, if you look at this growth chart, again, what you see is that this child is obese but short. Everybody who is obese should be tall. If you have a short stature with obesity, you're talking about Cushing syndrome, hypothyroidism, growth hormone deficiency, Turner syndrome, and Prader-Willi and pseudo-hypoparathyroidism. So there's a very number of causes which you can count in fingers in a short and a plump child. Short and plump is endocrine. So this case is not your run-of-the-mill constitutional obesity. If you look at the workup, what we really found out here that this was more like an endocrine pattern, and this child actually was found to have Cushing syndrome. So if you really look at the height age, weight age, plot the chart appropriately, you would be able to identify the right diagnosis in the right form, and that's something which is extremely important in that scenario. So I think this is what we want to discuss. I'll just showcase our algorithm, which we also developed specifically for short stature, which is actually using less amount of resources, providing the appropriate diagnosis in that scenario. So I think we'll close on that one. This will be the last part to cover, and then we'll close on that. So this algorithm is basically based upon clinical parameters. So first question is the child short? Look at high standard deviation score. It's above -2 standard deviation score, above first centile, follow up, reassure. If the height is less, the next question is the child short for family? And look at corrected height standard deviation score. If it's above 1.5, this is familial, follow for puberty, follow for bone age. If the child is short for the population, short for the family, the third question is the child short for the bone age? And if the bone age is less and high standard deviation for bone age is normal, this is constitutional delay of puberty and growth, follow. This is 80% of all the cases that will come to a pediatrician, in which you don't need to do any workup other than doing a pubertal assessment and a bone age. So growth chart, bone age, and puberty will give you the entire diagnosis in that scenario. But if you have a child who is short for the population, short for the family, short for the bone age, you start looking at systemic disorders. Now, what screening should be done? We recommend, of course, liver function, renal function, celiac, very importantly, in everybody. Blood gas below 3 years, because RTA without rickets, polyuria will be unlikely after 3 years. So after 3 years, no other features, maybe blood gas can be skipped in that scenario. If you find something, you treat, and if you don't find, follow up for growth velocity. However, if the height is very short, less than -3 standard deviation score, there is a 80% chance of pathology. We do not wait. We do these screening tests right at the beginning. Look for syndromic features. You identify syndromic causes. If they are not there, do a IgA level and karyotype in girls to identify Turner's and a false negative celiac in that scenario. Only after that, you go for growth hormone testing to identify growth hormone deficiency. And then you go for IGF-1 in that scenario. So this is a cost-effective way in which we are basically looking at the height SDS, corrected height SDS, height SDS for bone age. 80% cases are really eliminated there. Then go for common screening. We are putting karyotype a bit later so that before you go for growth hormone, you do a karyotype. Otherwise, you do karyotype in everybody. If we follow the GRS versus the Dutch guidelines, the cost of investigations becomes much lower in this perspective, and then you identify in that scenario. And we have actually validated this whole scenario, and this was published last year in JPEM, in which we really showed that our app had around 99% concordance. Out of 825 cases, 821 diagnosis by the app was accurate than what was the clinical diagnosis. So I think this is a way in which, if you just remember 3 things, is the child short for the population, short for the family, short for the bone age? Not short for the population, no evaluation. Not short for the family, this is familiar short stature. Not short for bone age, this is likely constitutional delay. Follow-up is what you will be needing. So I think that's what we wanted to just cover briefly, probably. Dr.
Thank you very much. Thank you very much, Dr. Anurag. Really, in few slides, how nicely you explained. Today, it was really a teaching session for not only pediatricians, I said for all endocrinology fellows, residents. Really, everybody enjoyed. Dr. Kalpana, please.
Yeah, I just wish to thank Dr. Anurag, Dr. Nandu, Dr. Asma. I think it was more like entire endocrine, condensed endocrine session. Maybe we'll cover the rest of the topics in another session, but thanks a lot for clarifying all our approaches. So I'm sure everyone has benefited a lot.
So I would like to thank Dr. Anurag, Dr. Nandu, Dr. Asma for joining us for this excellent discussion. I would like to thank Dr. Diagi. Unfortunately, he couldn't join us. And I would like to thank Tawfiq for sponsoring this webinar. A special thank goes to all viewers from all over the world following us even now. I would like to thank all of them. It's almost going to be 11. In India, it is, I think, 1 o'clock midnight.
Yeah, it's very late.
So thank you very much.
Thank you.
Hope to see you in next webinar with another session in pediatric endocrinology. Thank you very much and good night.
Thank you. Thank you. Good night.
Good night.
Good night.